we will be on time because it's a long day and we want to finish our schedule on time. So I once again welcome all of you on behalf of Ramakrishna Care Hospital, Raipur. And today our first session is head and neck cancer. So there is a slight change in plan. The session is the same, but first we will do the two talks and then we will have a panel discussion so that it will be more meaningful for panel discussion once the two talks are done. So for the first talk, uh, uh, I would invite Dr.
Asha.
Ashay Karpe sir. Dr. Ashay is a consultant medical oncologist and hematologist. He is a stem cell transplant physician also. He is a director of Sunrise Oncology Center and he is the president of Cancer Research Statistic Foundation Trust. Three sessions. I would invite our chairpersons so they can have come along with their coffee. That's not a problem. They can please take their time and come. Doctor, can you announce our list of chairpersons for the session? Thank you.
Yeah. So again, I request Dr. Rashmi Rai from Raipur, Dr. Saurabh Jain, Dr. Yash Chadda, Dr. Renu Rajguru, Dr. Surbhi Jain, and Dr. Rupa Mehta. Dr. Surbhi Chopra and Dr. Rupa Mehta, please join the dais as a chairperson. Over to you, sir.
Yeah. Okay. Good morning, everybody. At the outset, I would like to thank organizers, especially Dr. Ravi Jaiswal, because of whom I am in Raipur, because we have met long back in Mumbai, for some meeting. That time he said, promise that he will come, and definitely I said, I'll be there. And thanks for this wonderful hospitality. In fact, some of the people say, nightlife in Raipur is very good. So anyway, without wasting a time, I would like to make a disclaimer. Basically, this is a sponsored session by Merck, so all slides and data is presented by Merck. So I'm just presenting this slide. I've not made any changes in my slides. So basically, we will be speaking about a head and neck cancer, which is one of the most commonest cancer by site in India. And as we are looking at the therapy, so what are the goals of the therapy? So whenever we are treating cancer, if the cancer is not curable, then the goal remains palliative. And then what exactly we do? So today we will be speaking about non-nasopharyngeal cancer because nasopharynx is a totally different subset of the head and neck cancer. So treatment control, the goals can be symptom control or prolongation. It depends upon tumor location, what is the performance status of the patient, disease status, and now we have a pledial status, and whether he has received a primary therapy. The problem unique with the India is, this kind of situations, the patients has huge mass. So whatever is described in TNM staging, the patient actually goes beyond it, So we have such a huge masses, which are difficult to operate or difficult to get margin. So what are the expectations? When you have this kind of, disease, and we know, so this is our paper, which is when I was in Tata. So we wanted to know, ki whether all patients, they wanted a cure only, or actually what actually means their aim is. So almost, you will surprise, almost 60% of the patients, they wanted some sort of symptomatic relief. And what that can be symptomatic relief? They wanted to speak because, CA tongue or buccal mucosa, they are not able to speak, want relief from the pain. Some people say yes, they want to live longer, want to swallow the food because that they cannot even have their food. And some people say, it is so extensive, it is a social stigma. Whenever they go out, people are trying to avoid them, they are using mask or hiding it. So they wanted to shrink the tumor size. So this is, changes overall symptoms. So if there's a tumor responses are there, then patients were more accustomed to the therapy, and definitely their quality life and the overall survival is better. So this is a soccer trial, and where the treatment response to the cetuximab treatment was linked to a significant improvement in the symptom control as compared to with the non-responders. So this is with the pembrolizumab. Now, no oncology discussion is complete without a discussion on the immunotherapy. And we can see here the overall response rates when in the all patient population, you can see just 23.7%. In fact, the problem was here because we are seeing, there is huge tumors when we are looking at the oral cavity or oropharynx. The tumor responses were less. So if the tumor size is less, then the response rates were higher, 36%, you can see. But when the tumor size was more, then the response rate were as low as 14%. So here the median sum of response, the tumor size was almost 10 centimeter. So what are the tumor characteristics in the squamous cell carcinoma in India? Commonest are the gingival-buccal region and the tongue. And most of these patients are either advanced or the metastatic setting. The recurrent metastatic usually are locally advanced stage 3, 4 and often commonly present a delay in receiving their treatment. And almost 87% are the tobacco users, which has shown a poor survival as compared to the non-tobacco user, which is almost 43 versus 72%. So we have to, because we have most of these trials which are, we are using Extreme, we are using TP Extreme or Keynote. So all these trials, our subset of patient, how much were there? The Extreme trial, oral cavity was 21%, oropharyngeal 36, TAP Extreme it was 21%, and Keynote 04 it was 27%. So no tumor location subgroup analysis. So when we are analyzing the results, we are analyzing the head and neck cancer as a whole. But what about this subset? So these clinical trials, you can see, if there's an extreme phase 3, it's a oral cavity. The median OS was 11 versus 4.4 months, which is, favoring the cetuximab plus chemotherapy. Again, the change to phase 3, again, it is oral cavity, 9.3 versus 7.4 months, again, favoring the cetuximab. Again, the RWA, which is a retrospective threes, which is oral cavity has almost 19.7 months. And these are the certain Indian trials by Dr. Ankur Bahal. We can see oral cavity 12.23, Dr. Chandrakant. So all these trials, they are favoring the cetuximab plus chemotherapy. So the main problem, for the immunotherapy is that the oral cavity, it is not a very immunological hot tumor. So these are the immunological suppressive tumor. Hence, the immunotherapy responses are very less. So do all patients with the recurrent disease they benefit for immune checkpoint inhibitors with or without? So basically, this is a study Keynote 048 where pembrolizumab with or without chemotherapy in the recurrent metastatic head and neck squamous cell carcinoma, and you can see those were recurrent means all were not. So those were metastatic, they benefited, but the recurrent, the locally advanced, what we call, they were more favoring the cetuximab plus chemotherapy arm. So the proportion of oral cavity and locoregional recurrence in pivotal trial. So I'm not speaking of metastatic, locoregional. So you can see in the extreme trial was just 53%, TP extreme it was 35, and keynote it was 27%. Well, metastasis plus locoregional were 46.6%, and TP extreme it was 24%. So when we are looking at, this is the first side is showing, pembro versus cetuximab in the total population. So you can see almost it is favoring, but if it is look at this lower bottom, if it is a loco-regional, it favors cetuximab therapy plus chemotherapy. Similarly, when we are looking at the total overall population, again you can see if there's a loco-regional disease is there, again it favors the cetuximab versus monotherapy. So when we are selecting the patients, probably we will have to look at the tumor size, and we have to also identify, are we dealing with the loco-regional disease or the metastatic disease. So again, this is the patients who have received the cetuximab containing regimen. They had better OS in the loco-regional recurrence group than in the distant metastasis group. So again, we are sure what patient factor should be there when we are selecting cetuximab versus the pembrolizumab. Now, again, this is a pembrolizumab with or without chemotherapy in the recurrent metastatic Keynote 048. So, oral cavity is documented as a major cancer site in the Asian patients. And again, we can see here, it's, the pembro plus chemotherapy. If the locoregional disease is there, cetuximab is the preferred. So, again, these are the treatment outcomes of the cetuximab containing regimen in locoregional cancer. And we can see almost oral cavity was 50.5% patients were there. So, if the locoregional disease was there, 5.8 months was the PFS versus distant, it was 4.2 months. And overall survival in the locoregional disease was 15.6 versus distant, it was 9.7 months. So the ESMO guidelines basically, so if you look at the guidelines, we have very tricky, CPS more than 1 and CPS more than 20 you can use. But there is a huge gap between CPS 1 to CPS 19. What exactly is this? So Erbitux, the impact of Pembro on the survival of the patient with this CPS between 1 to 9 also need to be clarified. That is what the ESMO says. So CPS is an important decision-making factors, but interpretation of Keynote 048 is not straightforward. So patients with CPS more than 20, they made up 45% of the Pembro plus Platinum plus 5U with intention to treat analysis group, and 52% of the CPS more than one group, which is 85%, suggesting that the OS may be driven by CPS which was more than 20 population, and there is a range values between the CPS 1 to 20. So this data again, we what we see, if the CPS was declining, then the response rates were great. So OS benefit was mainly more than in the CPS more than 20. So cutoff for high CPS and low CPS, we really need to define that. So again, there's a large range between CPS 1 to 19, and cutoff between the low and high CPS is unclear. So the ESMO guidelines state the impact of pembro on the survival in these patients where CPS is 1 to 19, which needs to be clarified. So probably in the low CPS group, in the local regional group, you have high tumor burden, you wanted rapid response, then the cetuximab plus chemotherapy is the way forward. So this is a, when we look at, we are looking at those who survived, but those who didn't, what actually were there? So look at this overall response rates, in the extreme, which is a cetuximab based trial, and you can look at the overall response rates. So with intention to treat, 36, CPS more than 1, it was 35, and CPS more than 20, it was 36. So Pembro, even you look at, with the intention to treat, it is less, CPS less, more than 1 is less, but when you are having CPS more than 20, it is 23%. So with the CPS Pembro plus chemotherapy, so even you can look at, even when you are having the CPS which is more than 1, almost 39% of the patients, they will be having the progressive disease. So this highlights, the need to assess, okay, what CPS we are going to follow when you are using pembrolizumab. So efficacy of pembrolizumab, it decreases with the decreasing CPS. So you can look at when the in keynote 048, if CPS was more than 20, the median OS was 14.8 months, while CPS less than 20, it was 10.3 months. So with intention to treat was 11.5. So in patients with CPS more than 20, the addition of platinum plus 5-FU to pembro did not significantly increase the OS, but it also increased the toxicity. So pivotal first line trials, first line is extreme, which is a platinum 5-FU versus platinum 5 and cetuximab. Keynote 048, which is pembro, platinum 5-FU cetuximab, extreme kind of regimen, and pembro PF, which is platinum 5-FU pembro, and TP extreme, whereas a platinum 5-FU cetuximab and platinum docetaxel cetuximab. This has main, we have to understand that the PAs more than ECOG 2 and platinum refractory were not included in these studies. So treatment sequencing now becomes an important, pathway. So now when we are looking at the trial, now many of the times we are having PFS2, PFS1, all these parameters where you are able to control the disease longer, you are able to give them a second and third line treatment and better OS because of. So more treatment options are available. Improved treatment outcomes may, more and more patients, they are fit enough to receive the multiple lines. So primary endpoint is just not OS and PFS. We have to see whether patient can receive all lines of treatment. And these our patients want a meaningful increment. So this is a single arm prospective study. This is by Dr. Vijay Patil on the newly diagnosed patients. And look at, 96.3% of the patients, their minimum expectations of life expectancy at least should be more than 1 year. So what are the treatment sequencing option? Sequence 1 is first line cetuximab plus chemotherapy followed by immune checkpoint inhibitor. 2 is immune checkpoint inhibitor followed by cetuximab. Again, 3 immune checkpoint plus chemotherapy with cetuximab plus chemotherapy. So we always see, so basically whenever you were using anti-EGFR therapy prior, you make the tumor more immune responsive by the way of activating the immune system cells. So this is a TP extreme, again treatment with the first line TPX versus extreme followed by second line immune checkpoint inhibitors or cetuximab. And you can see when we are using cetuximab in the first line and second line immune checkpoint inhibitors, the overall survival is much better, 21.9 months versus if you are using the other way. So higher overall response rates and median OS achieved with the first line cetuximab to second line IO may be considered in patients, especially with the large tumor burden and urgent need for the treatment response. Because as we have seen earlier, the cetuximab plus chemotherapy gives the better overall response rates with a lesser uh, progressive disease. So better PFS1 and PFS2 with cetuximab IO versus IO plus chemotherapy. So other decision-making factors which needs to take into consideration, we have to understand the patient comorbidities, their organ function, kidney, liver, lung, patient preferences, what they actually want. Many of the times when the tumor is large, patient wants a rapid relief or they have obstructive symptoms. So we need to understand that if there is an underlying autoimmune disease, most of the times immunotherapy can be a challenging thing. They are disease-related, can be risk of acute complication like bleeding or the airway obstruction. Treatment dependency, residual toxicities from the previous treatment, availability of the re-irradiation or salvage surgery. Many of the times we have excellent responses and we can do the surgery. What actually you're looking at? So, somebody has already received a oral metronidazole therapy or vice versa. So where anti-EGFR is a part of it. So anti-EGFR followed by anti-EGFR is not going to give me much benefit. Maybe the immunotherapy will be there. And we have to understand these are certain expensive therapy. So socioeconomic status, availability of caregiver, and simultaneous availability of the palliative care. All these things are important. So with this, thank you very much.
Any question from the audience?
For any comment from anybody.
Excellent presentation.
In the first line, Nivo versus Pembro. Although platinum refractory nivolumab is a standard, and the first line Pembro is a standard. So CPS 20, if it is there, can we go for the nivolumab instead of Pembro?
See the trial. So if you look at the classically, means the initial trials, so biomarker-driven trials, Pembro criteria were always stringent. So unless you have PDL1 or CPS, the Pembro was only came when the PDL1 was there. Well, but Nivo never had any fixed criteria. So that's the reason why whenever you are assessing the Nivo trials, there will be responder pan whether they are PDL1 positive or PDL1 negative. See, the thing is that we cannot, so we can always say they are having the same mechanism of action and other things. But when you are having a CPS more than 20, as per guidelines, you should resort to pembrolizumab. You can go to, if the patient is frail, even pembrolizumab monotherapy or chemo plus. But we can always discuss with the patient because now with the availability of the biosimilars also with the nivolumab, so better, because I think what matters the most here, how long your patient can take the therapy and how long he can afford the therapy. So now we in India, supplies. I'm like we are fortunate enough to have multiple choices. So now we also have sertolizumab, which is again, so it is for the squamous cell carcinoma, definitely not head and neck. Right now, what we are looking is a small cell lung cancer and the esophageal squamous cell cancer. But these are the options which are always there. So goal here is just not to, follow the guidelines, but I think we have to understand. That's the reason why the last statement which I said, we have to look at the socio-economic status of the patients. So whichever treatment is useful, if you are able to give for a longer period, then only you will be able to achieve that response.
Thank you.
Sir, do I have time for one or two questions? One quick question. Yeah. So, in cases where there is a recurrent as well as metastatic disease, there are lung nodules,
Hmm.
but the major burden is at the local site or a regional site. How do you choose between cetuximab versus pembrolizumab? And the second, as rightly asked,
Yeah.
where do you fit nivolumab, low dose nivolumab in this? And as you also pointed out that there are certain patients who are already on Jeftinib. Now they are
Yes.
they come up and ask for the treatment. Do we give cetuximab after they have been on Jeftinib, or whether we should go directly to nivolumab?
So see, we don't have a trial where you have given OMCD. Probably all the trials would have given the cetuximab first. The only thing is that what I'm saying is a biological plausible mechanisms basically. So whenever you are given immune checkpoint inhibitors followed by EGFR, vis-a-vis EGFR followed by immune checkpoint inhibitors, the EGFR followed by immune checkpoint inhibitors seems to be better.
Better.
So first question again, I'm coming. If you have at the upfront patient who has a CPS more than 20, you are having a metastatic disease, my go-to forward will be chemotherapy plus pembrolizumab.
Okay.
I will not try to use pembrolizumab monotherapy because though we are having an excellent CPS, more than 20, the group less than CPS 1, definitely I'll be going more for the chemotherapy plus the cetuximab. The tricky group is a CPS 1 to 19. This is a very tricky group. So there I will choose, but even if I look at the rapid responses, if you look at the various, these factors also, the cetuximab plus chemotherapy seems to give a better overall response and less progressive disease. Again, that will be go to me between Pembro and Nivo, if I am using, because the PDL1 is not really that robust, I don't have that, of this group. So probably I will go chemo plus Nivo or chemo plus immuno both the way. If you look at the low dose Neo plus OMCD trial, it was actually essentially we were looking at the platinum refractory disease and other things. So those who are platinum refractory, not were on the initial anti-EGFR, maybe they have received. So we might switch to. But assume that the patient has already received a metronomic, then adding a nivolumab will not really be doing any great to that thing. So I will. So whenever you are having this bridge a therapy, so put chemotherapy or any other things because chemotherapy will give you advantage that it will reduce the immunosuppressive microenvironment.
Okay. Thank you.
Thank you, sir. I request our chairperson, please felicitate our speaker with a memento. Dr. Ravi Jaiswal, please join.
हाँ मैम प्लीज सर आप सेंटर में आ मैम इज HOD from एम्स हॉस्पिटल रायपुर so she will give on our behalf हम लोग सब साइड में आ जाएंगे मैम प्लीज मैम
Then next, we have a panel discussion on locally advanced squamous cell carcinoma, head and neck. For this, we have a moderator, eminent Dr. Amish Vora sir. He is the senior consultant medical oncologist, co-founder, director, Hope Oncology Clinic, Delhi. And to this session, panelists are Dr. Sneha Bothra from Raipur, Dr. Jaswant Jain from Raipur, Dr. Deva Dulal Biswas from Raipur, Dr. Ramesh Kothari, sir, Raipur, Dr. Gaurav Gupta from Raipur, Dr. Ritu Singhal from Raipur, Dr. Dipanjan Biswas from Raipur, Dr. Puneet Seth from Raipur, Dr. Naveen Jain from Raipur, Dr. J. Karthik from Raipur, Dr. Akhilesh Sahu and Dr. Divakar Pandey from Raipur. I request Dr. Rakesh Gupta sir and Dr. Shalin Kesharwani sir, please join the as a chairperson. Sir, in the sofa, please front row, sir. Sir. And Dr. Shalin Keshwani sir.
Yeah, we have here 12 panelists and here 10 people are there. 33639. Who's missing? Divakar Pandey. Okay, and Ramesh Kothari. So we have one surgeon less and one radiation oncologist less. Okay, okay, right.
Over to you, sir.
Okay. Uh, I thank Ravi. You always do a wonderful job. And both the times, even last year I was here, and there were two gynecologists yesterday. They met me and they remembered me. Ke, you were the first session last year. And thank you, Ravi. Continue doing the good work. So, topic which is given to me is locally advanced squamous cell carcinoma of head and neck. I think we all know that what we are going to discuss. There are two papers, neoadjuvant immunotherapy versus adjuvant immunotherapy. That is the flavor of this year. And we are going to touch upon the same. So we have Dr. Jaswant Jain. Yes, Dr. Jaswant and Dr. Dipanjan. Okay. So two of you, this patient is father of one of our colleague, 70-year-old gentleman, otherwise fit, uh, good BMI, no obesity, no comorbidities, and he had some lesion like this for 1 year. Two times the biopsy was done, and both the times the biopsy was negative. Finally, they went to the third place, and there the biopsy came as squamous cell carcinoma. Just both the surgeons, if you can opine on this, if you are able to. No neck nodes were palpable.
It's a biopsy proven case, so obviously the first thing would like to do is to image it and see how infiltrative it is because it seems to be going to the bone. It's eroding that
Right,
ridge.
right,
So
absolutely.
Yes, it clinically it looks like malignancy only,
No, it
and
is biopsy proven malignancy. Now, third time the biopsy was done. So this lesion is over a year. And in clinically, that's what I wanted to ask. Clinically, can you make out that is it eroding the bone?
more assessment can be done when we do palpation actually. but it's very near to bone mandible, so maybe there will be
Maybe
erosion.
there will be there. Dr. Naveen,
So,
you want imaging.
yes, sir, definitely. We'll advise for CT
So
scan.
this is the MRI, which is there. Neha is nodding her head. Uh, so bone hai. Okay. Anybody here who doesn't feel that there is no bone involvement here? So this becomes T, T4. Clinically, right now it is T4A N0 disease. This was the PET scan which was done. And the PET scan also, if you see the third image there, it was classical that the bone is eroded there. So let me ask, what next? What would the panelist, anybody would want any further information? We have MRI, we have PET, we have biopsy. Anything else anybody would want to have? Yes, please.
Uh, like I'm hellbent. I'll operate on this case. The next thing I would do is like say pre-operative assessment, and
Patient is
also the
fit. Pa-
reconstruction will need something from like say fibula. So I might be getting angiography of lower limb. What the PRS wants. So
okay,
every investigation now, what I want is either for the surgical fitness or for the reconstruction.
okay. So according to you, surgery first. So that is what it is. We have two other surgeons. Uh, you both would say surgery first, Dr. Naveen and Dr. Dipanjan.
Yeah, traditionally it's surgery first. Obviously, we uh, generally we do plan for surgery first. But
You will plan for surgery first. Dr. Naveen, plan for surgery first.
Yes, sir. Basically, we'll plan for surgery first, but according to newer like we can say the era of this modernization, we can go for like PDL1 marker also for that same.
You would go for PDL. So PDL1 on biopsy is 55% by TPS. ये रियल केस है, बनाया नहीं है मैंने. So now what? Radiation oncologist and medical oncologist, please. Uh, would you, how many times, in case if you have to give neoadjuvant chemo immunotarget, how many times is the tumor board? How many times do you fight in tumor board that surgeon says surgery first, radiation and medical oncologist says no, not done? How many times it happens? Let me ask Sneha, and we also have Dr. Ritu and Dr. Karthik, three medical oncologists. Four medical oncologists. Okay.
Sir, it
Medical oncologists dominate. Dr. Deba. Ha, 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 ha. Please.
Sir, till now, the surgeon has to take the call. If surgeon says that it is operable, then conventionally we agree, sir. And for the
Conventionally, you agree. Okay.
T4B, in T4B cases, T4B, in T4B cases, they tend to send to us or inoperability or large bulky tumor, something like that.
Okay.
But here it is conventionally, it is, sir, surgeon will take it.
Surgeon will take the call. Any other medical, any other opinion?
Sir, if it is upfront resectable and the patient also agrees, we go ahead with the surgery.
Okay. So today,
Discuss
today we are
neoadjuvant
sitting. Today we have 14th of June, 2026. We have two trials back to back. Okay. Now, do you argue with the surgeon, even though it is operable? See, there is a paper. Let me give 2 doses of immunotherapy in this patient.
can consider neoadjuvant immunotherapy.
So 4 out of 3 are my medical oncologist. Till 6 months back, I was very happy. I was the boss. 70% of my work being in head and neck. For past 1 or 2 months, Karthik always pings me regarding this, and I am feeling a bit uncomfortable these
सर आप
days.
बैठे भी बॉस के जैसे ही हो अभी. Okay, Dr. Karthik.
It would be, I would leave it to the patient decision. Basically, I would explain the both pros and cons of taking neoadjuvant immuno and going upfront resection. So,
Okay. So this patient has PDL1, TPS more than 55, CPS must be more than that. And this is an NCCN guideline where it has been incorporated immediately if PD-L1 positive neoadjuvant pembrolizumab except N3 disease or clinical trials. These are the two options which is there. Yes, surgery preferred is the top one which is written. So how many of you would agree that yes, this is a practice changing paper? Neoadjuvant immunotherapy. This is doctor's father, T4A, so far N0 disease, but T4A disease, uh, stage 3 disease is there. And you have now almost like a FDA approval category 1 recommendation. Why would you not give immunotherapy in this patient? I would like to know.
The MRI did not show any lymph node, sir. It is not a
Yeah,
bulky disease. It
yes,
is T4A only,
right.
still operable. So there is
All the patients
so
with
and there are
keynote.
two trials are there, sir. One is post-op is also there.
Okay,
So in
okay.
that view,
So you would wait for Nivo post-op in this particular patient?
probably, sir, because it is not
Probably.
T4B.
Agreed. Okay, fair enough. I think that is the option which is there. What about yes, all the we are coming to radiation oncologists, but about other three medical oncologists,
Would not
neoadjuvant as per the guidelines or wait for Nivo post-op. He has a fair point.
It's an oral cancer and that too node negative, resectable.
Keynote 689, there were 40% of the patients had oral cavity cancer.
But sir,
And
since
if the PDL1 was more than 10%, the hazard ratio was 0.66. If you have everything fitting, you have the guideline and you have the FDA approval also.
but
uh, when it comes to the trial keynote 6, I would not, I would still wait for a real world evidence. I have two main reasons for it. So primary, even though it showed a primary EFS, it didn't prevent any loco-regional recurrences in the trial, and only advantage was distant metastasis-free survival. Considering this patient, which is node negative and locally this thing, so chances of being a distant metastasis is very unlikely to in a future. So this is a
This is the
yeah.
reason. So, the primary endpoint in both the trials was event-free survival, whether local, regional, loco-regional, or distant. And both the trials were exactly sitting at 0.74 HR hazard ratio. Both were trial positive. Keynote is the only trial which is FDA approved. Nivo post-op is still not FDA approved.
but sir, when we look at the paper, uh, from starting till the end, the number of patients who were progressing and the number of patients who actually went into the trial were like almost 60%. 40% still had from the starting till the end, they progressed. So if we wait for 6 weeks in the upfront resectable patients, there are highly chances that the patient might progress also.
Okay. Surgeons, were you worried? All the three surgeons, what she said, that you give two doses of neoadjuvant immunotherapy. That means 0 and 3, and then wait for 3 to 4 more weeks. So 6 to 8 weeks for surgery, and you lose the critical period of surgery. Were you worried?
Yes, definitely. That's
You
a
are worried.
I'm more
Boss,
worried.
I'll call you now boss. Boss.
I'm more worried if the disease responds beautifully.
You are more worried if the disease is, and why
Because
so?
because in breast cancer it's proven, okay, if there is a we do BCS, if there recurrence, we always have a chance of mastectomy. Nobody is seeing the other side of the coin, that an operated patient or a patient on chemotherapy with a limited resection with radiotherapy coming back and going again. Going again is never easy in head and neck cancer versus breast cancer. Three patients of CA tongue left side,
Hmm.
all two patients complete path response, and one was having skip lesion as good as the recurrence was when the patient was on my table.
On your table.
Yeah, and all the three patients were having supple tongue. MRI is showing some residual fibrosis. So till the time plan of resection, whether if it is as per the initial disease or as per the current status is clear, I'm more worried if the disease responds.
If the disease response. Fair enough. I have a slightly different thought process, but yes, you are the surgeon. We are sitting on the other side. So far, if we conventionally go for surgery, we all are looking at 50% 5-year survival rate in stage 4 disease. We need to move beyond that. And to address your question, if you look at the trial, 88% in both the arms underwent surgery. So that means upfront, you have counseled 100 patients for surgery, 88% landed up. As compared to in the neoadjuvant IO arm also, there were 88% which were there. The main problem is hyperprogressors. And like he said, two patients on table were found to be inoperable because they were found to be progressing on immunotherapy. So I think these are the few patients which are there, which we have to worry about. So as I was talking that this got the FDA approval in June 2025. Dr. Anupama Huda Nehra was our colleague in Max Hospital and she was one of the part of that. This is the Nivo post-op trial, which was there, which is absolutely there. So what I understand, everybody's right now decision is to go for surgery upfront, and my medical oncology colleagues will wait for Nivo post-op, or anybody here is for neoadjuvant IO. Any of the panelists will give 2 doses of Pembro, or surgeons will push them. Look at the surgeon is pushing them for.
Yes, sir. The reason behind that, I'm working with Dr. Roy now, and the concept is that we will give a not customized treatment like that. Patient is having like suppose a person is having a t-shirt size ML, like we are going in malls. We will not give that. We will see the patient first. That because you told sir that his aged patient.
70.
We'll see the all condition first that what he is going to be benefited with like big surgeries like prefibula flap. So we can give an option.
Sir, if you allow for a minute.
Yeah.
So let's say if the patient would have been a young guy, 30, 35-year-old, and has got a lesion on the tongue, going to get married in, let's say, 6 months, 8 months, would you approach change when your PDL1 is 55, 60? Because I have couple of patients such, and I've put them on neoadjuvant chemo IO protocol, and both of them are showing fantastic response. One got operated, I think ma'am operated 1 week back, the young guy Rohit. So he was married 6 months back. So it was such a havoc for the family. I mean, when you get diagnosed at a pretty young age, and tongue cancers, these guys get at a young age. And sorry, just one, sir, but then if you are scared, if patients are responding so well, I think the audience is getting scared because we want patients to respond. What message are we giving them that they should not respond? Just a
No,
joke.
I think what he was trying to say is the plane of
response,
plane
problem
of
is
recurrence.
recurrence, long term,
Yeah,
maybe 2 years.
yeah, plane of recurrence. So tell me, if marriage is after 6 months, and they say, sir, marriage ka kya kare? What advice do you give them? We keep getting off and on these type of. No, I'm asking very seriously, ethically, what would you tell the patient? Patient says, sir, मेरी शादी 6 महीने में है.
Partner to be above, really getting married, I think no one can stop now. So how you and me can stop there?
Okay, we have to tell them. Okay.
A very important point that sir has raised. Now you're getting very good responses after immunotherapy. Now, how do you decide your resection? In breast cancer, you can just take away whatever is the residual disease. But in head and neck cancer, we have all have burnt our fingers. The disease has responded well. Even MRI shows that the disease has shrunk. But in your final report, or even a pathologist says my frozen is very tricky. I cannot tell you whether this is a post neoadjuvant chemo or immunoresponse versus this is actually negative disease. You are sitting in your operation theater, you're standing and you are confused. What margin should I take? Should I go from the point of view of the first disease? Like he said in tongue, it's very, very tricky whether in this case you go from the initial disease or whether you will see the response and resect whatever the residual. And we all have seen that patients recur at the local site. We have done our good job. The patient and the family is very happy that you have preserved a large part of the lung, of the tongue. And 6 months or 1 year later, they present with recurrence and in a married state, and you are confused. You are saying, "Oh wow, what a good response we had," and you're doing quite well. But actually,
I
we
get
don't
your
know.
point.
So in
Yeah.
in head and neck cancer, the surgical resection based on initial judgment versus based on post neoadjuvant
I
response
got your
is
point.
still
I
tricky.
think I got his point also. This reminds me, I'm not an oncosurgeon. This reminds me of Dr. Devender Chauker's one seminal paper neoadjuvant chemotherapy and the preservation of the mandible. So upfront, the mandible had to be operated upon. After neoadjuvant, there were 50% of mandibles could be preserved. So I think now surgeons, especially head and neck oncosurgeons, need to move forward and decide.
Sir, I come.
Correct?
No,
The problem is we don't have a second chance in head and neck. Problem is head and neck is a tricky area.
yes,
We
exactly.
don't have second
Right.
chance.
I think two ma'ams and then we'll move forward. We have 7.5 more
Yeah, I
minutes.
work in Balco Medical Center. We do get these kind of cases in our tumor board. And for I've been practicing since around 9 to 10 years. And I've found that with the maxilla T4B lesion, recently Dr. Deva came to my clinic. Why you want to give chemo immuno to this patient? Why you're not operating? Because I've seen that when you give in NSCT setting with immuno, there is definite reduction in the disease, which is because I agree with you. That's not
Maxilla
the
is
case.
different,
It
ma'am.
is case to
Maxilla
case
is a
basis.
different
I
body.
have to take a judge. Like when it is very close to
What
the
is your
test.
point, ma'am?
The point is that we have to find a case where we have like T4B lesion, which is like we can get an R1 resection when we go upfront. But for the R0, this kind of a resection, we should go for the surgery.
We should go for it, sir. Point well taken, ma'am.
So, in spite of being a medical oncologist, I think it's a new study. We need more data, and we understand that these studies has been done more in the Western people, and our people we have more aggressive disease. What is our experience? I think all of us will share that our patient they have more aggressive disease. So maybe we need to have more Indian data. We need to have more experience. And in a patient who is upfront operable, probably I will not take the risk of getting it progressed further. uh, Again, if it recurs, as Dr. Jaswant said, it's a big problem. More important than I have to have more Indian data for me to be more confident, because I think we have seen it many times that as Western literature have seen many CA tongue T1 N0 NCCN says observe, and we have seen if we put such patient on observation, they recur very fast.
I
I
got
think
your point.
the biology is different.
I
So
got
we
your
need
point,
to
ma'am.
take things with a pinch of
Yes.
salt.
So,
Sir,
I got your point. 1 minute, ma'am. I unfortunately, sitting on the Raipur, Ravi may not call me. This is the mentality where we are not able to move forward. Trust me, in Tata Hospital, when I was there, I had a project. I believe that Indians are different, Asians are different. Our genetic pool is 80 to 90% of Caucasian pool. All the drugs which are FDA approved, tell me, give me a single drug where DCGI has not approved sooner or later, and we have not used in our. I'll tell you why I'm saying that. All these patients were operable patients. Keynote 689, all of them, 100% of them. Not a single patient was stage 4B. They had not included. They had included stage 3 and stage 4A, which can be easily operable by any of these surgical oncologists sitting here. They still tried. They wanted to go beyond 50%. And this is the curve. If you see right from the word go, the curves are separating after 3 months. My point is, ma'am, take your own call, depending on the biology. But to say that I'll wait for some more time, I think probably, some patients who could have benefited today. This particular patient, I'll tell you, I would have given neoadjuvant for 3 reasons. PDL1 more than 10, 55. Second, patient had 1 year history of this lesion, slow growing disease. Patient was absolutely fit. Still, nodes were not involved. I think just 2 doses of immunotherapy probably would not have done harm. But I take your point very well that we need to look at our own biology. If we have that data, absolutely fine, ma'am. I'll move forward, skip. This was the reason. This is also, I'll skip. This was the pathological complete response. If you see, still 13% major pathological response. Um, I still feel that this was something we still need more. Lung, we have reached up to 18 and 20% complete pathological response rate. So this was my reason of giving neoadjuvant. But unlike me, everybody here was right. Patient underwent surgery upfront. I tried to convince medical surgical oncologist in Mumbai. I completely failed. He said almost the same like you all said. He said, let me Amish operate first. And this was the histopath report. PT4A, PN3B. We have 3 more minutes. I'll take 1, 2 more minutes. Is that okay? Okay. So if you can make this 5 minutes, I'll be happy. So this was now retrospect. Any of you feel, and we have 5 minutes, I would want radiation oncologist now to speak. Sorry. But now retrospectively, do you think our decision would have been different or fair enough? This is the biology of the oral cancer. You can't change it.
It's totally opposite. I mean, what we see and what we get. So here it's a T4A and 3B.
Yes.
So now retrospectively, we can say that you are correct. I mean, can we think about as per the NCCN guidelines, the CP score are high? Why not we have offered new adjuvant?
Correct, correct. Right. So, neoadjuvant immunotherapy, since you have the mic, sir. Sorry. No, no, a radiation oncologist, please. Since you have the mic, in neoadjuvant immunotherapy arm, the dose of radiation compared to 66 gray, it was 60 gray in the that neoadjuvant. Do you think that with such high nodal, would you compromise, or do you think the biology would have changed and you are okay giving 60 gray if there is a good response?
No, still it's a need more trials to confirm it. I mean, I still give higher dose, being a N3 disease and aggressive biology. I mean, I prefer to give higher dose.
You prefer to give higher
Actually,
dose.
sir,
We
the
have two other radiation oncologists,
the
please.
trial was an intensification trial, not a de-escalation trial. That
No, it was not the de-escalation trial,
we
but
will
what they found in that chart, 66 gray in the post-op arm and 60 gray median RT dose patient who had received neoadjuvant immuno and those who had responded. That was, you are right. There was no de-intensification
we
plan.
tend to give same dose.
Tend to give the same dose.
Sir, actually, this is a high risk case, N3B, nodal, extranodal extension. And also we look for margin status and give higher dose, 66.
Give higher dose. So this patient becomes stage 4B now. So what? Only CTRT, or have you read about Nivo post-op? You would tell in the tumor board, I'm comfortable giving nivolumab with CTRT in this patient.
Yes, sir. Either we go with CTIT with cisplatin or aid according to post-op, neo-stop trial.
Nivo
Neoluma.
post-op trial.
Nivo post.
Nivo
Post-op is bit better.
Nivo post-op is better. Okay. All three medical oncologists now, Nivo post-op, Nivo post-op, Nivo post-op. Okay. Everything. Now we give everything what we can because as everybody is saying, patient will not get the second chance.
I beg to differ with the new post-op trial.
You beg to differ. Okay, fair enough.
If it was actually we have to look into the statistics why it's not FDA approved. Even
Why
though
it is not FDA approved. Okay.
that gives an answer for this question, I guess. So it's a investigator initiated trial. The investigator assessed DFS was like 0.73, but still it was a very good PFS. It's comparable with the Keynote 681. Still, FDA has not approved because if we one of the secondary endpoints of this trial was blinded independent central review committee assessed DFS. That DFS was hazard ratio was 0.89 with uncorrected, and that was crossing a hazard interval of more than 1, confidence interval of more than 1. So it was kind of a negative trial. Basically, when they adjusted for the incorrect assessment by the blinded BICR committee, the hazard ratio was still 0.81, and still it was crossing the confidence interval of 1.10.
So there was
was
some, you are right, there was some blinded issue. And because of that, some 23 events, FDA was not sure whether they are over estimated or underestimated. If it is overestimated, the hazard ratio would be 0.81. If underestimated, the hazard ratio may go down below 0.73 also. And that's why still now it is not approved. It is still under scrutiny. You are right. But going by the curves, so I'll just show this is stage 4B, and there was 45% of patients in Nivo post-op were stage 4B, and this was the loco-regional relapse differences. If even if you take those 23 out events, still we had a sizable difference in the loco regional. I completely agree. I agree with every word what you have said. It is not FDA approved, but trust me, this is this year's fourth panel, mine across India. Everybody wants Nivo post-op. hardly anybody wants Keynote 689. I don't know the reason why. Either I'm thinking it differently. Every colleague of ours are comfortable with Nivo post-op right now. So this was the local relapse which was there, and this was a 3-year event-free, 52 versus 63%. First time in head and neck cancer, we had something 10% beyond which was there, and it was there. So if this patient, all the three radiation oncologists, last question, my time is up now. Um what nodes do you cover? If this patient would have been, say, N1 disease, PN1, what is you cover what nodal area in this particular patient?
So N1 at
Especially, say, after neoadjuvant, if it is N1.
after neoadjuvant chemo
Immunotherapy.
immunotherapy. If N1 is at the submandibular region, so I would cover till level 4 in ipsilateral side and level 3 on the contralateral.
Contralateral side.
Yeah, agree. Agree.
Agreed, same.
Yes, sir. Ipsilateral in intermediate risk and contralateral is in low risk.
Right. Absolutely. So, and all the three radiation oncologists believe that you will not reduce the dose, even there is a very major pathological response. Because the trial, they did that from, and they found that grade 3, grade 4 toxicities of RT in the IO responder arm reduced by 15%. So you are not comfortable reducing the dose right now.
Right now, no.
No.
Right
We'll
now,
give
no.
same
If
dose.
any, some trial shows that it is better or it's equal quality, then
Then we can
we can
think of.
consider.
Okay, perfect. Fair enough. I think this was my last point, that how many stage 4A clinically turn out to be stage 4B pathologically, something which we need to understand. So this is where we need to understand both the trials are practice changing depending on where you select which patient. Both have its pros and cons, and you need to discuss in tumor board. But now we need to move on. We need to incorporate immunotherapy in our head and neck cancer treatment, especially stage 3, stage 4. With that, I thank all the panelists, and apologies if I have not included some of you properly. Sorry. Thank you.
Thank you, sir.
I one question for the moderator.
Yeah.
I just want to know, post this neoadjuvant immunotherapy in the subset setting you told, has any study being done of what is the type of pathological response we achieve?
Yes. So
Because whether it's a concentric response based on which a surgeon can take proper margins, or it's a Swiss cheese type of a pattern response where we can get trapped post surgery. The tricky situation is just
we trust you surgeons so much that we don't bother to look at that. That's your job to look at that. But you are right. I have not read any paper like Swiss cheese or like that. I really don't know about that, so I won't be able to answer.
Because if the
This is what they have said.
Yeah.
This is what 13.7% if the PDL1 CPS more than 10 is a major pathological response, which is we are still not happy. Medical oncologists now want more and more. Dil mage more. Even lung cancer we have reached as a complete pathological response, which we never thought we would reach.
For your question, only one comment is there. If you are going for the neoadjuvant chemotherapy, you can reduce your margin, post chemo margin. If you are going for the neoadjuvant immunotherapy, you cannot reduce your margin because immunotherapy have the patchy pathological response. You might lose. So neoadjuvant immunotherapy, go with the previous margin. Neoadjuvant chemotherapy, go with the
So that
post.
is what the trial had said. They had agreed upon the margin before giving the 2 doses, and they stuck to those margins. They did not reduce. But Devendra Chaukhar, as we said, he has shown that you can preserve the mandible even though if you give neoadjuvant chemotherapy. We have that paper, OK trial, which is there. Thank you so much. Thank you, sir.
Thank you. I request our panelists, please felicitate our moderator, Dr. Amishwara, sir. I request chairperson, please join the stage for a group photo. close to the stage. I request our panelists and chairperson, please collect their mementos from the memento podium, which is just outside of the hall. And I request Dr. Ujjwala and Maura Madam, please present mementos to our panelists and chairpersons. Now we move to next session. Yes, ma'am. Yeah, okay, you can.
You allow?
Please.
It was an excellent panel discussion, and with blessings of Dr. Rakesh Gupta sir and AOI, AIMS Raipur is hosting their annual conference. The theme is head and neck surgery, oncology, and rhinology. And I invite, on behalf of Rakesh Gupta sir, I invite all panelists who were present here, along with the moderator, to please participate in our conference, which is on 8th and 9th of August. We will have an excellent academic meeting, and who's who of head neck cancer are coming. You must be aware of a few names I may say: Dr. Prathamesh Pai, Dr. Abhishek Vaidya, many faculty from PGI, MAMC, all institutes of national importance. And I humbly request you to please participate in our conference. Thank you.
Thank you, ma'am. Now we move to next session. We have uh, on lung cancer. Speaker is Dr. Girish Agrawal, consultant pulmonology, Ramakrishna Care Hospital, for his talk on evaluation of solitary pulmonary nodules. To chair the session, I would like to invite Dr. Dipesh Maske, pulmonologist from Raipur, Dr. Avinash Chaturvedi from Raipur, Dr. Varsha Vishwanath from Raipur, Dr. Devraj Vivekan Pillai sir from Bhilai, Dr. R.K. Panda sir from Raipur, Dr. Akanksha Sada from Raipur, Dr. Balakrishna, Dr. Balakrishna from Raipur, Dr. Dibakar Sahu from Raipur, Dr. Roshan Rathor, Dr. Jyoti Das, and Dr. Kasaf Javed. Dr. Kashaf Javed. Over to
Kalash. Kalash. Good morning, everyone, and I extend my warm welcome to all for coming into this OncoSphere and to all the hangover guys. Until I saw my friends, I realized most of you present here are sober. Then I thought, no, okay, we have some company. Okay, so solitary pulmonary nodule, this is probably one of my darkest introductory slide. And the reason is I gave my presentation to my DNB student and he used cloud AI for making the slide. So at the last moment, this guy was pushing me to give me slide, but I was preparing the slide on my own at the last moment. So you will see few colorful slide which are from the AI and very basic plain slide which I have made on my own. So my thanks to Dr. Ritik, my DNB student, and while I was coming to the conference, I got to know that Nupur also helped in preparing the slide from cloud and to the AI cloud. Okay, so we'll start with a case. A 50-year male, women, sorry, who had a history of smoking of one pack per day for 15 years, which she stopped 2 years ago, was diagnosed with abdominal liposarcoma 2 years ago. She had resection with chemotherapy and radiation therapy, and during surveillance computed tomography, 2 centimeter of pulmonary nodule was noted. Right. So the patient has been reluctant for aggressive management. What is the next best step? To my chairpersons or any of the from the audience. A repeat CT scan after 6 weeks, PET scan, CT guided biopsy, EBUS, or a wedge resection.
So it is a peripheral. You can see in the CT scan of the lung, it is situated in the base. But she doesn't want to be too aggressive regarding her treatment. So what is the next best step?
No, the size is already 2 centimeters. If you look at the guideline, if any size nodule which is more than 8 millimeter has to be evaluated.
Okay, how will you? That's the question. How you want to evaluate?
So now
Because she doesn't want to be aggressive.
no, no, 2 centimeters is too big. We cannot ignore it. If it had been less than 8 millimeter, then the guideline says that you have to do a serial CT scan for every 3 monthly, 6 monthly, and this. But this, since this is a 2 centimeter on a background history of already malignancy,
Yeah.
I cannot ignore it.
Yeah.
If the patient doesn't understand, despite our your aggressive counseling, that is a different issue, and you just have to write down that patient is not willing at the moment. Otherwise, this patient has a high risk of malignancy and should undergo any kind of biopsy. Since it is a peripherally, located nodule, CT-guided biopsy would be the first choice. But now people are going, because the risk of pneumothorax is very high in CT-guided, so people are also going for a bronchoscopic guided biopsy. If the patient is in a confusion model, if you require something to emphasize more, you can do a PET CT scan and look for uptake. If the uptake is high, then you can further reinforce. But by guideline, this case requires biopsy.
But as you are suggesting that she is not ready for going for any invasive procedure, the best way to evaluate is just check the doubling time by a repeat CT scan after 6 weeks.
Okay, so you want to repeat the CT scan after 6 weeks, and Dipesh want to do CT guided biopsy. Any more comment about EBUS? We are pulmonologists. Come on.
EBIS for this case, we won't be able to do since it is a peripheral pulmonary nodule. However, we can plan for a CBCT or robotic, but
Pardon? CCT.
For that, we need to look into the airways. I will look at yeah. See, radial EBUS is we can do a radial EBUS guided biopsy in this patient. The only challenge in this case would be that once the patient is intubated and the patient goes into anesthesia, there will be a lung collapse. And that lung collapse, if happens, it becomes difficult to identify a atelectasis and a nodule. Unless you have to, there are protocol of IP protocol and doing things.
Okay,
So I would prefer a CT guided. It is easier, cheaper enough.
since today is the era where anyone who has got an instrument, he thinks it is a hammer and everything is nail. So we have radial EBUS at Ramakrishna, and we got this patient, one more patient, 50 years male, deformed smoker, 1.5 month history of cough, shortness of breath, weight loss, and 5 days history of hemoptysis. And this was referred by Dipesh only, and we did EBUS, and this was the lesion where we found from the EBUS. We took a EBUS guided ball, and it turned out to be tubercular. Now, why I'm showing this case, we'll discuss in the case presentation. And the answer to the question which we ask is a CT guided thoracic biopsy. Now, radiographic evaluation depends on the size, number, and degree of opacification of a nodule. Anything which is less than 3 centimeter is nodule, more than 3 is mass, and less than 8 needs to be characterized in many ways. So this is again a slide from AI, and they have defined that partly solid nodule less than 8 when we are talking, we define it as in a ground glass solid or partly solid. Highest risk of malignancy is by partly solid nodule, which turns to be 67%. The lowest is a solid nodule. Right. So when you characterize a nodule, there are certain characteristic which can say this nodule appears radiographically to be benign and this nodule appears radiographically to be malignant, out of which speculated margin is the one which carries the highest risk for being malignancy, besides bronchoalveolar sign, air bronchogram, cavitation and all. One clue to the clinical diagnosis is post IV enhancement. If the enhancement is less than 15 Hounsfield unit after contrast, it is most likely a benign. If it is more than 20, it is most likely a malignant. And these are all the type of radiographic finding which can have in a benign and malignant nodule, from the air bronchogram sign to the ground glass to solid nodules.
then there is a reason why this happens. I'm skipping this part. Now, sub-centimeter nodule, as I said, less than 8 mm, they needs a further characterization, and all the guidelines are pertaining to basically the incidental finding of a nodule. One thing which is very important for defining solitary pulmonary nodule is it should not be associated with atelectasis, pleural effusion, hilar lymphadenopathy. A incidental solid nodule without any other finding on the radiography is defined as a pulmonary nodule. Now, there are different classification and ways to approach a SPN. ACCP has its own approach, Freshness Society has its own approach. More or less, they remain the same. And they have divided again the patient into high risk category for malignancy and low risk category for malignancy. Now, there is a certain timeline for each cancer patient from the onset of nodule to the onset of symptom and its progression, as Dr. Pillai was talking about the volume doubling time. Right. So, less than 4 mm, less than 5 mm are usually non-malignant. So, less than 4 mm, you can have in a high-risk patient, you can do it yearly, once at 12 months, and let the patient go if there is no change. 4 to 6 mm, every 2 mm increase in the nodule decreases the interval of CT scan by half. So, in high risk, if 4 mm is 1 year, then 4 to 6 mm, you can have 6 months and then a year. And if it is 6 to 8 mm, you can have 3 months, 9 months, and a year. Right. Upper lobe, important clue in radiology. If besides a high risk for malignancy, if it is an upper lobe nodule, it carries more chances of malignancy than a lower lobe nodule. And same with the Freshness Society, they extended from 8 to 15 and more than 15 mm also. And the CT scan time decreased to 3 months. But if it is more than 15 mm and it is persistent at 3 months, then you need to biopsy it. Right. Volume doubling time, how we assess is if it is growth has increased by more than 2 mm in a mean diameter, how to calculate mean diameter, there is a formula to it, or more than 25% by volume. Because doubling time of a solid nodule, if it is malignant, it is 200 to 400 days. 400 to 600 days, very less chances, and more than 600 days, you're gone. So 400 days corresponds to an year, right? So that's why every till 1 year you follow a solid nodule. But the same does not goes with the GGOs or partly solid nodule. For solid nodule, 1 year, even in high risk patient, you can carry up to 2 year, not more than 2 year. But in GGOs, you have to carry up to 5 years, right? Even in solid nodule, if there is a resolution of nodule over a period of time more than 8 mm, then also you have to follow it till 2 years before you declare, okay, it is not malignant. So it is again based on the volume doubling time, and GGO may remain stable despite malignancy. 5-year follow-up is recommended for GGO nodules. ACCP on partly solid and solid nodule less than 5 mm, they don't recommend any further evaluation. More than 5 mm of ground glass nodule, 6 months. So ground glass nodule and partly solid nodule are more malignant. As we saw, we need a more vigilant eyes. For part solid nodule of less than 8 mm, 3, 12, and 24, follow up till 1 to 3 year. But if a part solid nodule is more than 8 mm, at CT at 3 months, as I said, if it is more than 8 mm for GGO, and as if it is more than 8 mm for partly solid, if it is more than 8 mm for solid nodule, and if it is more than 8 mm even in part solid nodule, persistent at 3 months, we need to biopsy it. And one more important thing for the part solid nodule, if there is increase in the solid component of the part solid nodule, then we need to do a biopsy. Clinical tips, less than 10 mm nodule are usually adenomatous hyperplasia or AIS. AIS and invasive adenocarcinoma are more prevalent if there is more than 50% of the solid component. PET scan is not recommended for any nodule less than 8 mm, specifically less than 5 mm. So, PET scan, they have very high sensitivity, mildly low specificity, but negative predictive value is very high. But still, PET scan can be falsely negative in lipidemic carcinomas, in carcinoids, in adenocarcinoma, or in nodule which are less than 8 mm. So our question, non-surgical biopsy versus CT-guided biopsy is the correct answer. Reason, non-surgical biopsy is recommended for more than 8 solid if the clinical probability of malignancy is low to moderate. If there is discordance between the probability, clinical probability in imaging test, given the peripheral location of the lesion and patient desire for least invasive approach, CT-guided biopsy is preferred. The reason for CT-guided biopsy, it carries very high sensitivity of 90%. Now the question is, if the patient is aggressive, what would have been done? So if the patient is aggressive, then a wedge resection or thoracoscopy is recommended. I think there are certain pitfalls in clinical diagnosis to it. Speculated margin carries the higher risk of being malignant, but it can be benign. Similarly, the smooth margin, 20% of the smooth margin can be malignant, right? Slow growing GGOs are often missed. Part solid component inside the GGO is often missed. Non-application of the Fishner Society or the ACCP module. And then there is a formula from the Mayo Clinic and BTS and everybody who calculate the probability of malignancy and they decide on the resection. So things are to be taken into consideration with the symptoms, with the radiology, with the guideline, rather than just thinking me as my tool as a hammer. Thank you.
Any comments from the audience? Okay. I request our chairperson, please felicitate our speaker.
Just one last question. The evaluation of solitary pulmonary nodule as well as intensive lung cancer screening is very well established in Europe and in the American. What about India? Have we come to the prime time to initiate lung cancer screening in our context? Because is it the right time? Have
So
we
we
crossed it?
agree we need to, sorry Dipesh for interrupting, we agree we need to have a surveillance CT scan, but how many of the hospital really follow low dose CT protocol? And how many of the hospital has a facility for low dose CT protocol? Exposure. So there's a huge, I don't, can't give you the exact number, but it is the basically the minimum exposure of the radiation giving you the maximum output just done for the screening purpose. Yeah, yeah.
I think, sir, for the high risk group, smoker, smoking pack here, more than age more than 50, smoking pack here, I think 30, there should be screening. One example is there, one of my colleague doctor, actually because of the COVID era, doing CT scan, found to have a 1 centimeter nodule and he got operated. Still 6 years, he is alive, disease free because he got the diagnostic CT scan because of the COVID era.
So 1 centimeter nodule.
1 centimeter nodule.
And he got operated immediately.
We did the biopsy, PET scan, biopsy.
So there was no follow up.
Sir, it was
so we didn't follow the Fishner guideline.
Sir, we actually follow. Actually, we 1 centimeter nodule doctor radiologist.
So
there is a lot of.
Thank you for bringing that point. We works in our whims and fancies, and that is the most important concept while we are dealing with SPN. As I told you, clinical, radiological, proper follow up of the guideline protocol. Look, if we start doing surveillance CT scan in India, the scenario in India and the scenario in the West are quite different. Once you told in the West that, okay, we have find a nodule, we'll keep following, it may turn into a cancer, the probability of cancer is this, you are a high risk, but we still follow, they understand. Here, one single CT scan, incidental finding of 1 centimeter of nodule immediately got resected.
Sir, lung cancer. No.
No, I'm not
lung cancer.
What I'm saying, no, what I'm saying is, we are planning, we are discussing, should we go for a surveillance CT scan without a change in mindset? That's what we are discussing.
You I think, sir,
Okay.
Mass screening, yeah.
Dr. Girish, Dr.
last
Girish,
point is
For surveillance. Yes. Yes.
so
so
only
we'll
point, sir.
close the session.
Yes.
Okay. So which cutting biopsy needle you are using, and what is the incidence of pneumothorax in your setup? You're using
Sir, I have to ask the radiology guy, but we are using this gun biopsy.
gun biopsy, cutting biopsy.
Gun biopsy for
Is it a true cut needle?
incidence
The
of
needle which is used for
pneumothorax.
liver biopsy, same?
Incidence of pneumothorax again is determined by the location of the nodule. How much lung you have to travel. That depends on what is the underlying condition of the lung, because in smoker there are high probability they are emphysematous and they will have a in high incidence of pneumothorax.
I request our chairpersons, please give a memento to our speaker, Dr. Girish Agrawal. I'm repeating few names. Dr. Avinash Chaturvedi, Dr. R.K. Panda, sir, Dr. Balakrishna, Dr. Roshan Rathor. If are you here, please join the dais as a chairperson. Dr. Kasaf Javed also, please. Now we move to the next session. I would like to invite Dr. Bharat Bhosle sir from Mumbai for his talk on the rise of precision oncology in lung cancer. Dr. Bharat Bhosle sir. He is senior consultant medical oncologist from Bombay Hospital and Medical Research Center, Raipur. Over to you, sir.
So again, thank you, Ravi and team. I must talk about rise of oncology in Raipur. So 2 decades back in Tata, when we used to talk about this area, Suman Madam used to be the name. And now I see there are youngsters from no 3 year coming to from Mumbai and no settling here. I think I must congratulate all of you for having this wonderful meeting. Sunday, the house is full. So the topic was rise in precision oncology. Obviously, everybody is busy. I am also a little bit busy. Then I look at you youngsters and the AI, everybody is using AI, LinkedIn, Facebook, and I decided, let's try it. And I struggled, then I decided, no, I came to know that this is not my cup of tea. And whenever such topic comes, I personally feel rather than talking about the data being presented in ASCO, we have daraxonrasib, and the drug will come in 2030. So that's not a precision for me. Obviously, it's a breakthrough. It's a great breakthrough. What is accessible and feasible to our patients, which reaches to the patients, is far more important than the graphs we talk always in the conferences. So we should talk about a real world precision. So that's what I have been doing. So no conflicts. Again, no use of AI in these slides. These are, again, as usual, I'm a old timer now, oncologist, though I look a little bit younger. So I will talk about history. Whenever such topic comes, I go back to the history. I speak to my seniors. The lung cancer has evolved from FNAC era. Nowadays, if somebody advises FNAC, हम बोलते हैं अरे क्या है कहाँ से जमाने से सीख क्या है FNAC कर दिया. When breast, lung, we talk about tissue. Tissue is an issue. Whenever lung cancer comes to my clinic, most of these patients go on oral therapies. We do not keep any conflicts because no, they don't take chemotherapy. Still, I put my heart into it. I talk to the radiologist. I talk to the pathologist myself. And most of the medical oncologists or surgical oncologists are doing that. I keep on troubling, intervention radiologists, give me maximum tissue. So it has evolved from the stage based. Unfortunately, lung cancer, most of these patients presents with no higher stages. There was a time when we used to struggle between only small cell and non-small cell because small cell used to be a troublesome disease. In 2000 to 2010, when the histology has evolved in terms of IHC, and the first paper came, Dr. Purvish was one of the PI of that paper where pemetrexed versus paclitaxel used to be the discussion, and we used to trouble the pathologists. IHC में क्या है बताओ, no? TTF1 and all. That was the era. Forget about the EGFR. We used to struggle for IHC. Adenoia is good. We have pemetrexed now, less toxic. Otherwise, you have to have docetaxel, paclitaxel reactions. The paclitaxel cost was more than the nivolumab. I have used a paclitaxel which was more costlier than trastuzumab, pertuzumab, and nivolumab. Generic I'm talking about. So that was the era. So it was a nightmare. Hardly any drug, and we were very excited. Pemetrexed is coming. Pemetrexed cost was 80,000-90,000 then, more than the combination of pertu trastu. So that was the era where no we struggled with this, and slowly we moved towards 2007-8 when life was becoming easy. One day I was on the rounds and Dr. Kumar Prakash came up. We were two residents in Tata Hospital. We used to manage the entire buildings, 3 buildings. And there was a patient, and he said, write this drug because there was a lady, non-smoker, and the results of EGFR, used to hard. We evolved in terms of IHC, then DDPCR. Sequencing was something which is in the dream. People used to talk about circulating tumor cells till that time also. We still not into practice. And he said, patient was PS4. These reports used to go and take 30 days to come for the biomarkers. And Tarseva or Iresa was the two drugs. These are the brand names. And the cost of Jeftinib or Erlotinib was 1.5 lakh rupees there. So no, that was the cost of Jeftinib. Now you get 500, 700 rupees. And he just went off. I went for my rounds. After 7 days, the same lady started walking. And we used to have similar results in the clinic before the biomarkers. So that was a courageous step that time. And 90% of the patients were not affording for Jeftinib that time. Only those who are railway reimbursements or who used to know. So we actually see then versus now. Now we have so many trials to discuss, beautiful graphs to discuss. In 2026, still the poster child after the BCR-ABL is the EGFR for us. We have NG sequencing, ADCs, and the 5-year survival graphs used to look something like less than 5% people used to survive. Now we have 50% plus. If you look at the EGFR history, the history started in 1960 when Stanley Cohen actually thought of these epidermal growth factors and their receptors. And 84, it was subsequently published in Nature. And 1986, the Nobel was awarded for EGFR discovery. So this was the gentleman, both of them, and this lady who received the EGFR discovery 84. And imagine from 84, it took 2007 for translation to a drug. So these are the activating mutations. So this was the first discovery in 2004. And the first paper, they were not aware about which are the activating mutation. They just gave the drug and they looked retrospectively. Why it is important? Now we have a paper of Keytruda, neoadjuvant, you have a DFS benefit, FDA approved. Still our medical oncology colleagues and the surgical oncology colleagues are debating. We will keep on debating. After 2 years also, I'll come here. I think we have to act upon. We have to look at how the precision is moving fast. In this trial, they looked at the responders. They went back. They looked at the EGFR. And then they came to know L8858 and the DEL19 were the activating mutations. And this was the lady who presented in 2004 in Massachusetts General Hospital, where she had a brain metastasis in 2004, was enrolled in the first trial, which was IPAS, and she's still alive. 2004 brain metastasis EGFR, which is largely a story of ALK, but still in a clinical trial, obviously we have to work, but Indian realities are like in head and neck you are discussing. This paper comes from West. Obviously, some of the patients were from Max. Our patients are totally different. The biology is different. They progress fast. Within that PSC also, I used to see in Tata Hospital, patients' blood sugar we used to send to a diabetologist. By the time the blood sugars are controlled, patient used to become inoperable or borderline operable. So we really have to understand the biology of our patients. So this again comes from the West. These are the graphs. which improved from 1970 to 2010. And now the only challenge for us is the accessibility of the drugs. So actually, I spoke about 2004 to 9 was the dawn of precision oncology, where we actually know when I was completing my DM, the first abstract of 84 or 80 odd patients of ULK came, crizotinib. And we amazed looking at those responses. There was no comparative trial. It was just the responses we started writing that drug. So we have these differentials. Like for daraxonrasib in pancreatic cancer, we clapped in ASCO for 1 minute standing ovation for a drug which is going to come in 2030. And now again, we will keep on debating. But precision is something which we have to know upon. Then subsequently, many mutations come. ROS came, BRAF came, RED came. But something which is happening with EGFR and ALK or ROS, we don't see in translating into other mutations. But still, we have drugs. And again, I said how to get access to these drugs is very, very important. So I will not go into details of all this sequencing or ctDNAs. So I mentioned about 30% odd patients. Fortunately, in Asia, we have 33% of the patients are EGFR positive, as opposed to the West, where only 10 to 15% or 20% maximum are EGFR positive. So KRAS was the mutation we used to talk. There was a time when a geneticist who came from US, and so she used to say, you first do KRAS. If it is negative, then do the other mutations. There was a sequencing testing. Now you send a NGS and you get a report in 10 days or 14 days. There was a time we used to struggle with the reports. So motion was like you do KRAS because 30-40% of the patients, maximum patients are KRAS positive. And we struggle to have a drug. When we started having this drug, again, still we struggle because the cost is a problem and the responses. Then came the EGFR unusual mutations. We came to know that this is a very difficult to treat. And now we have a drug, antibody drug conjugates. This ASCO, especially the HER2 and EGFR exon 20, the drugs are coming. Hopefully, we should have access. I think only way where we can have access is having a network of research where we can push the ways to invest in the research over here, and our patients can get access to these drugs. This this graph is always been shown what are the percentage, and you see EGFR and KRAS dominates. So this is not a story of 1 day or 2 day or 1 day or 2 years. Now we have combination of chemotherapy with TKIs, and you see at 4-5 years, nearly it is touching to 50%. These are stage 4 patients, asymptomatic. Sometimes they are asymptomatic brain mets. The probability of going beyond 4 year or 5 year is nearly 50%, where that probability was 5% or 6%. Any patients who are mutation negative used to survive for 6 to 8 months in 2007 to 9 or 10, and the story changed after 2010. Problem is nowadays we have access to best possible laboratories, and when the reports comes to us, we keep on scratching our head what to do because the complexities are so much. We are getting too much information. What to do with that? Apart from the actionable mutations, when a medical oncologist writes a test, he should be very clear what I'm going to do with the information when it comes in my hand. Something like pre-test counseling and post-test counseling. There has to be counseling of a medical oncologist by geneticists also, or there has to be a crosstalk in between. When you write a test, you need to know what results I'm going to get and how I am going to act. Because patients are now getting access to Chat GPT, and they come with the questions. As I said, if you call a patient of head and neck, they are going to ask you about the checkmate or keynote trials or post-op neuro trial, because this is in public domain and the Chat GPT is going to give them that option. You should be ready to answer all those questions. Then the diagnostics has evolved. I briefly mentioned there was a time when we tried with ISC for EGFR. Obviously, it failed, but there was a time for two. But the ISC story for ALK was fantastic. I will cover up in one of my case. And now, as I said, we are looking at the whole genome sequencing. We should know the fallacies of liquid biopsy. When one is writing a liquid biopsy, we should know what references the laboratories are using, what reads they compare with the internal and external control. Because sometimes, see, geneticists are not going to use the drug. It is the patient sitting in front of you. So you should put your mind, you should go to the laboratories and you should know the intricacies and complexities of these reports. Then only we can practice a perfect precision oncology. Obviously, there cannot be a perfection. Everybody can't be Amir Khan. But yes, you have to step towards precision, because precision says it's the right drug for right person, by right person, for the right person. for the right, actionable mutation. Still, I feel no for all our patients, unfortunately, no, they don't have access to all these drugs because the cost is exorbitant. Last week, I tried to get Capiva Certip. The cost is like 6 lakh rupees per for for AKT mutations, and the drug will come after 1.5 months. For sick patients, if you order such drug, we end up in getting the drug when the patient is no more. That has happened in the past, no, with most medical oncologists. So acting on time is also very important. When you have the information in hand, when the patient has spent 3-4 lakh rupees for the report, that is where no this. So this is my first case where no lady, non-smoker lady, came with a breathlessness, and she had a mediastinal mass. There was nothing in the lung. So with great difficulty, we did the medicinal biopsy. One of the good pathologists in Mumbai had this report. Just 2-3 minutes, 20 minutes हो गए. So this was reported as thymic, but I suspected it's not thymic carcinoma, and we reviewed it with my friend Jay Mehta, and it was a lung cancer. I questioned him, but this is lung cancer, but tissue was inadequate. Then I took a blood, sent for assessment, and we got a report of Ross fusion first, and we acted upon it. It disappeared. It disappeared. The problem was to have access to the best possible drugs or not there. I gave only crizotinib. After a year, patient started coughing, and these are the serial pets. And if you see, the first was thymic. We gave one chemotherapy. There was slight reduction, but again, patient landed up in emergency with cardiac tamponade. We tapped it. Whenever I get opportunity to get a fluid, I prepare a block. The patient got better. By that time, I said, no, liquid biopsy was already placed. Loss report came. We gave crizotinib. The third graph is within 2 months of giving crizotinib, completely disappeared. See, this is the impact. Then after a year, start progressing. We discussed the biopsy. It was very close to the vessel. We could not do the biopsy. Again, a blood was sent. But then I remember there was a cardiac tamponade fluid I sent along with. So solid liquid combination gave me these results. So it was actually in a subsequent liquid biopsy EGFR, and the primary cardiac tamponade, it was EGFR positive. We added just jeftinib to crizotinib and subsequently had excellent responses. Later on, she developed brain mets, no systemic metastasis, systemic control. We gave brain RT, she landed up in casualty. The second last one was extensive disease one. But when she was in ICU, we did a BAL, it was tuberculosis, gave AKT, disappeared completely. Means it is a clinical intuition. One more case, I'll completely finish this. This is very important. So this is how it works. 1 minute, 1 minute. So this young boy came from Dubai with convulsion, brain metastasis, and PET was done. There was a supraclavicular node. We made an effort to do frozen. It was adeno. And when my pathologist saw the histology, he said, "No, we always do discuss." He said, "इसमें कुछ अल किया, no, something will come." And he also said, "अल का आएगा." Then finally he gave me reports. No, it is negative because I see only 2 reads. I said, no, nothing doing. This is positive. You send me the tissue bag. Other I'll send to other laboratories. He said, I said, why don't you try IHC? By IHC, it was strongly positive for ALK. We started him on ALK inhibitors. The boy is still alive 4 years. Subsequently, he had MET mutations. We acted upon that also. So this is the story of precision. You have to question the results. You have to do something extra. You have to have a cross-talk with your pathologist. And this is the way forward. When there is a data, at least we should discuss with our patients before the patient gets to us. Because as I said, in today's era, patients have the information in their hand. It is the time that you write the test, you should know how you are going to act in this way. So with great knowledge, I'll just lastly move to my slides, because two most interesting. So medical oncologists are like this. When they get a lot of information, you can save Uncle Ben. And this is what's said by Spider-Man in 1960s comics. You can rewrite DNA on the fly. But with this take like that, you could cure cancer. This is not us. It is Spider-Man in 1960s comic. And when you get a great knowledge in terms of NGS, the great responsibility lies on the shoulder of an oncologist. And we should be able to deliver that. People feel that no oncologists are enjoying, but we do all surgical, radiation, and medical oncologists. We do read a lot of information comes. We do feel bad when we lose patients. But if we act in time, then we feel proud of ourselves. So acting in right time is a precision, apart from no choosing right drug, right patient, right mutation. Thank you so much. Thank you. Any questions?
Excellent talk, and for a pulmonologist, it's an eye-opening because we just do a biopsy saying for the tissue. When it comes to malignancy, we refer to oncologist. Then we don't know the journey beyond that. So it has always been a very interesting. Since now we are more picking up to precision therapy, but then we come across many a time the patients respond initially, and then there is a relapse, and many times there is a mutation going on. So in our during times there was this ELK mutation and EGFR are mutually exclusive.
Yes.
So now NGS coming up. Do you see only a single kind of mutations that's going on, or there are multiple mutations simultaneously going on?
So we have been telling these tumors are very smart. What I have learned, no, I think you try and suppress one pathway, they try and adapt the other pathways. We are now, that is why we are trying to know combine chemotherapy with EGFR. That paper came from no Dr. Vanita and Kumar from Tata. We are adding chemotherapy for those P53. P53 was something which started knowing after no this NGS, but not all P53 are bad. I have been doing a lab research where I look at, if you look at, there are some P53 these patients still go on, but adding, as I said, acting in time. So that is how we started combining chemotherapy. For immunotherapy also, we started giving 2 cycles upfront, and then so somewhere these clones are evolution. Some clones are at baseline, they are suppressed, and under the pressure of the treatment, they evolve. That is what happening in breast cancer, endocrine therapies. These ESR1 clones are evolving. Sometimes the AKT mTORs are there at baselines. I had a lady of stage 1 breast cancer. Oncotype DX was 15, and she relapsed within 3 years. No answer for that. Okay. That relapse. Retrospective lipolytic is the invasive lobular carcinoma. So IDCs and ILCs are totally different, and their relapses are also across the skin. It's not going to the viscera directly. And now we did a biopsy in the liver. It is AKT. For her, I have no ordered capivasertib. So even if you see that this is low risk, it's not that easy. That is where the role of no extensive sequencing comes. But again, as I said, when you are writing that, you need to know what you are looking at, for what drug you are looking at, and not always this actionable mutation information helps. Beyond our what data is provided by lab to us, we should go and ask them what is the background data, what is happening. There are a lot of mutations are happening which may be actionable in the future, which we are reporting as VUS. Your strong family history, young patients with triple negative and they give VUS may not be reported in the literature. You start collecting the data. We have to keep this data because our genomes are totally different from the Western. Largely, we have no reference laboratories, Western laboratories. I personally feel all the Indian laboratories should come together and have their own data set that will help us. Because these 2 reads of what I showed, ALK, is a positive thing, which will be reported as a negative to you, and you will not act on it. I asked for more data, I got the answer.
Excellent.
Um, Today, the science has moved to molecular genetics, right? In each and every field, we are getting more into genetic detail rather than and we are phenotyping, genotyping, and everything. As far as pulmonology is concerned, we deal with the ICU and we get this highly marketed lavage sample or blood sample having PCR, biofire, and you get all the information, but where do you need to act is your clinical decision. Same thing goes with the oncology. Absolutely. Right. So whenever you send this mutation part, you have a complex of mutation lying in front of you. And we start picking up, okay, ye kaam nahi kar raha hai, this is the common, ye de do, nahi kar raha hai, ye de do. But do we really need to follow those mutations? Because in our cases, in BioFire, we don't follow that. Yes. And over a period of time, since BioFire is still dominated by the clinician choice, BioFire is getting extinguished.
Agreed.
Now people are not using BioFire, though it has been heavily marketed. So with lot of information coming on the mutation, this mutation, that mutation.
Got it. I got the one. Last question, I'll answer that. Because the first case, no scenario I showed 2004, the EGFR was positive, but not all patients responded. So similarly, when you get unusual mutation, you should go to the reference laboratories, have word with the geneticists. Don't take the call again alone. Sometimes these mutations are not translating into this thing. Sometimes there might not be a mutation. The problem is happening at methylation level. You will not see the mutation, And now they are trying the methylation profiles where no, you can pick up more mutations because the things are happening not at the genetic level but at the translation level when no methylation or acetylation problems happens. So we are evolving, but for apart from the common mutation, we should discuss if something like no unusual mutation comes. It may be actionable, it may not be actionable because the drugs are very costly. You can't just act. If you get no KRAS, you need to see whether it is actionable because KRAS 1 2D in the stories now we have been seeing. Yes,
That's where means we are trying very new
yes,
and
yes.
costly drugs at firing every
Absolutely,
mutation.
absolutely. So biofire like thing will be tomorrow's medical oncology. You will get 2,000 rupees NGS costing. No, within 2 days you will have information. The patient now we have time to read 10 days. Now patient will you write a test 2 days after patient will come. You have to be on toes like you guys. There was a biofire when started. We used to get COVID reports also,
Yeah.
but we never acted on that. Right? COVID was reported that time in the biofire. What I remember. No, he's just saying that oncology is evolving towards that level. Yes, yes, yes. Absolutely. For unusual mutation.
No, I am talking when we get complex mutation of.
So
We have so much of noise in the report.
so background mutation we don't act unless you have no proven record of actionability. Yes.
Yes, it's a noise. Yes. So I think we can
Thank you
close
so
the
much.
session.
This is a wonderful
Close the
Thank
discussion.
you. Thank you.
Yeah.
Thank you.
Continues.
Thank you. Our chairpersons still have to. Yeah, please. I request our chairperson, please be seated there for another two topics. Next topic is the tale of two stories redefining treatment outcomes with Mariposa 2 and Papillon. Please be seated, chairpersons. And for this talk, I would like to invite Dr. Rohit Pai, sir, from Mumbai. He is a senior consultant medical oncology, Bombay Hospital and Gleneagles Hospital, Mumbai. Over to you, sir.
Good morning, everyone. Thanks to Dr. Ravi for the invitation, first of all. And I'll be talking about basically amivantamab in the exon 20 insertion, as well as the second line treatment post osimertinib. The slides have been provided to me by Janssen. So the current outcomes of advanced NSCLC, EGFR mutation, even in those patients, there is room for improvement. And with the first line osimertinib, only around 18% of patients survive beyond 5 years. That is a very important thing. In the Flora study, the median overall survival was 38 months approximately, but the survival beyond 5 years is around 18%. That is something different as opposed to ALK, which you have a long-term survival beyond 7 years in many of the patients. So the goal is to maximize the duration of treatment, improve the median PFS and median OS. So most patients with first-line EGFR TKIs develop progressive disease due to acquired resistance. The time frame for progression is 9 to 15 months for first or second generation EGFR TKIs. And for third generation EGFR TKIs like osimertinib, it is around 18 to 19 months. Osimertinib is the current standard of choice in the first-line setting. The median PFS 18.9 months, intracranial PFS of 15.2 months, and median OS, like I said, it's approximately 38 months. The tumors eventually become resistant and disease progression occurs. And there can be a very heterogeneous sort of acquired resistance to osimertinib, which might involve the on-target mutations, which might involve MET amplifications, which might involve alterations in cell cycle signaling proteins and MAP kinase pathway too. One of the most common mechanisms is MET. The other common mechanism is on-target mutation, EGFR 797X mutation. and usually they start to occur after 12 months after treatment with osimertinib. Obviously, after treatment with osimertinib, you also have a morphological change sometimes, that is a small cell transformation, which can only be detected by a tissue biopsy, and for that you require chemotherapy. Osimertinib plus chemotherapy also sort of has a similar sort of a resistance mutational profile as opposed to compared to osimertinib alone, because osimertinib plus chemotherapy in the FLORA2 is coming up as a one of the standard of care, with a PFS sort of from 18 going up to around 24-25 months. Now, how do we overcome resistance to osimertinib? We can give fourth generation EGFR TKIs for on target inhibitions, which are still at the experimental stage. We can give drugs like ivonescimab, which have a PDL1 plus VEGF blockade. We can combine the on target and off target inhibition like osimertinib plus tepotinib, osimertinib plus savolitinib. And we have the ADCs, of which probably datopotamab deruxtecan is expected to be launched in India, which we can use in the EGFR TKI resistant patients. Platinum-based chemotherapy is the standard of choice following progression on osimertinib. It was so with an overall response rate of around 27%, PFS of around 5.5 months, and overall survival of around 14 months. But now we have amivantamab for these patients who have been treated with osimertinib in the first line. And amivantamab essentially has three mechanisms of actions. It is a bispecific inhibitor of EGFR and MET. It degrades the receptors and also has got immune action. And again, it blocks the ligand binding, and it also bypasses the EGFR independent and it bypasses the EGFR independent resistant pathways. And essentially, amivantamab in combination with chemotherapy has been also shown to improve the intracranial responses to these patients. So when we are having a patient on osimertinib, what do we do? NGS testing should be performed on progression. Ideally, a tissue biopsy should also be performed, because it is seen that in patients treated with first-line osimertinib, the small cell transformation rates are more than those with first-gen or second-gen TKS. So ideally, you can consider a tissue biopsy also, especially if the PFS is short, maybe 8 or 12 months. We can consider that it might be a transformation rather than some resistant mechanism. And real world studies show that post osimertinib progression, the chemotherapy only shows a PFS of around 4.7 months. Now we come to the Mariposas 2 study, the first study which I would be discussing. Amivantamab plus chemotherapy with or without lazertinib versus chemotherapy in EGFR mutated advanced NSCLC after progression with on osimertinib. And this essentially had patients with EGFR exon 19 deletions or LH5 mutations who were progressed on osimertinib monotherapy. Stable brain metastases were allowed, and essentially there was 2:1 randomization to amylazar chemotherapy versus chemotherapy or amylazar chemotherapy. So essentially, in this particular analysis, we are talking about amivantamab plus chemo versus chemo. And the dose for amivantamab 1400 milligram for the first four weeks, and then 750 milligram, 1715 milligram every 3 weeks, starting at the seventh week. If the weight was more than 80 kg, the dose was 1750 and 2100 respectively. And the certification factors were whether it was osimertinib was given in first line or second line, Asian race versus non-Asian race, and history of brain metastasis. Now, essentially, Mariposa also was unique in to have the CNS surveillance. So there was a periodical MRI brain also being done along with the systemic staging. So these were the baseline characteristics which were comparable. And essentially, you can see that the history of brain metastasis was present in approximately 46% of patients in both the arms. Now, this is the first and only regimen with a significant PFS benefit versus the standard chemotherapy regimen. So the median PFS was 6.3 months with amivantamab plus chemo versus 4.2 months with chemo alone, hazard ratio of 0.48. There was a consistent PFS benefit across all the subgroups according to the performance status, history of brain metastasis, whether osimertinib was given in the first line or the second line, and also the type of EGFR mutation, whether it was exon 19 deletion versus LH5. there was a progression-free survival advantage even among Asian patients. So this subset is somewhat controversial in Flora 1. So the Flora study, the Asian subset did not seem to benefit that much with osimertinib. So basically, since then, Flora 2, etc., have said that this Asian subset is also benefited with chemo plus osimertinib. But now the trials are actually concentrating on this Asian subset of patients. And even in this, there was a 46% reduction in the risk of death, 0.54 hazard ratio. And efficacy is consistent among Asian population. What about the overall response rate? That was almost double, 64% with the amivantamab plus chemo versus 36% with chemotherapy alone. So the objective response rate was almost double. And there was a significant intracranial progression-free survival benefit also with hazard ratio of 0.55. Intracranial PFS 12.5 versus 8 months. There was early and sustained separation of the curves, and also the intracranial efficacy is demonstrated. There is a sustained response in CNS2. Also, in patients with a history of brain metastasis, no prior brain radiotherapy, there was a better intracranial activity with amivantamab. Also, there was a trend towards overall survival, and the OS curves also showed an initial separation. The PFS2 was also improved with amivantamab. So the subsequent therapy post giving amivantamab plus chemotherapy was also better, 13.9 versus 11.3 months. Adverse events, essentially the adverse events leading to the higher grade adverse events were seen, but mostly the median treatment duration was also more for the for patients on amivantamab, and mainly there was higher neutropenia and thrombocytopenia, especially in cycle 1. VT events, no grade 5 events, because VT, venous thromboembolism, is something which is sort of for many of the regimens. For example, amilazartinib, they are recommending first 4 months you give prophylactic anticoagulation, but there was no grade 5 VT events. Rates of discontinuation due to VT was low, and the ILD rates were also low in both the arms. Thrombocytopenia, myelosuppression, especially in the first couple of cycles, but they were not treatment limiting. Hematological adverse events, again, major in probably the first cycle 1 is more seen. Cycle 2, essentially, it's same in both the arms. So summary, second line use of amivantamab plus chemotherapy after progression on osimertinib, a prolonged PFS 6.3 months versus 4.2 months, 52% reduction in risk of progression or death. Prolonged PFS2 13.9 versus 11.3 months, higher overall response rate 64% versus 36%. Benefit also seen in Asian subset of patients, reasonable adverse event rates, and essentially the triple mechanism. So blocking of the extracellular domains of EGFR and MET, degrading of receptor and activation of immune response. This is essentially the standard of choice for patients who are treated with osimertinib in the first line, which has been included in the NCCN guidelines and the ESMO guidelines. Now we come to exon 20 insertion. So exon 20 insertion is only seen on NGS. Please remember, when we are doing the hotspot mutation, we used to miss this exon 20 insertion. Dr. Bharat gave a wonderful talk about molecular profiling, and exon 20 insertion is only seen on an NGS. And the rates in South Asia, Southeast Asia is approximately 1 to 3 to 1 to 4% according to the studies. Now, this was exon 20 insertion Apilon study, which looked at the addition of amivantamab to chemotherapy versus chemotherapy alone. Again, documented exon 20 insertion in the first line were studied, stratification factors according to PS, history of brain metastasis, and prior EGFR TKI use. The dose used for amivantamab was the same as the Mariposa 2 study, and the chemotherapy was pemetrexed 500 milligram per meter square until disease progression, and carboplatin only given for the first 4 cycles, AUC 5. And the primary endpoint was PFS. There were multiple secondary endpoints. Now, this was the randomization schema. And essentially, the history of brain mets were again present in approximately 1/4 of the patients. Primary endpoint, the PFS advantage was seen 11.4 months with the addition of amivantamab to pemetrexed carboplatin chemotherapy versus 6.7 months with chemotherapy alone. Hazard ratio of 0.39. And essentially, here also you are seeing an early separation of curve and a sustained separation of curve. Hazard ratio of 0.40 that reflects a 60% reduction in the risk of progression or death. The difference of PFS rate at 18 months was approximately 10 times. This is very important. So there was a sustained response also with the addition of amivantamab. 31% progression-free patients at 18 months versus 3% with the chemotherapy alone, in the chemotherapy alone. There was a consistent benefit across the subgroups. Also, the Asian subset did seem to benefit equally, and the combination therapy also so basically demonstrated consistent benefit across subgroups. Overall response rate was also improved. The overall response rate with amivantamab chemotherapy was 73% versus 47% for chemotherapy alone. There was higher rates of complete responses, 4% versus 1%. Median time to response was also quicker. So it was almost 6 weeks for amivantamab and chemotherapy versus around 11 to 12 weeks. So almost a double time to response with the addition of chemotherapy. The difference in overall response rate is 1.5 times responders. So 47% versus 73%. Duration of response was also improved. So the median duration of response for amivantamab and chemotherapy was 9.7 months versus 4.4 months with chemotherapy, and the sustained response. So you are seeing that at 18 months, 34% patients are on have an ongoing response versus 4% patients with chemotherapy. So this is as per the blinded independent committee review. The investigator assessed DOR benefit was also seen, 13.5 months median versus 6.8 months median. Doubles duration of response. So this combination did double. PFS2. The PFS2 benefit was also seen. So beyond amivantamab and chemotherapy, in case of progression, we are treating with subsequent lines. The median PFS2 benefit was also seen in amivantamab and chemotherapy arm with opposed to chemotherapy arm. It's not estimated versus 17.2 months. So again, first line use of amivantamab plus chemotherapy is supported. The subsequent lines also seem to do better with the use of this combination. The overall survival, there was a trend to overall survival, not estimated in amivantamab chemotherapy arm versus 24 months, hazard ratio of 0.67, and PFS trend, the hazard ratio of 0.67, 33% risk reduction. Adverse events, again, the patients with AMI chemo were longer on treatment. Serious adverse events and adverse event leading to death were comparable in each arm. So grade 3 adverse events are more 75% with AMI chemo versus 54% with chemotherapy alone. But treatment-related discontinuations of amivantamab were low, 7% only. So a manageable safety profile, severe adverse events sort of comparable, and a low treatment discontinuation rate, 7% with amivantamab, 8% with chemo alone. So again, EGFR and MET-related adverse events were increased. So MET-related adverse events essentially are things like edema, hypoalbuminemia, EGFR-mediated are rash and paronychia along with diarrhea. Neutropenia was transient and majority of the events were not serious. And pneumonitis was reported in around 3% of patients with the AMI chemotherapy arm. So this is for Papillon study, amivantamab chemotherapy in exon 20 insertion improved the PFS versus chemotherapy in the first line. Amivantamab chemotherapy had consistent PFS benefits across all predefined subgroup, higher overall response rate, and a longer duration of response, a longer PFS2, and a favorable interim OS trend. And there was low rates of discontinuation with amivantamab, 7% only. So it represents the new standard of care for first line patients with exon 20 insertions. Adverse event mitigation. So amivantamab, what we are more concerned about is thromboembolism, cutaneous side effects, and allergic hypersensitivity reactions, especially in the first couple of infusions. So skip IR is dexamethasone 8 milligram oral prophylaxis starting from day -2. This is very important. Usually for vaccines, etc., we give day -1 only. For this, we have to give from day -2. So 2 days before, 8 milligram dexa in the morning, 8 milligram in the evening. 1 day prior, the same dose, and 1 hour before the infusion, you give 8 milligram dexamethasone. So essentially, this has reduced the risk of infusion reaction by threefold reduction. So 67% without the dexa versus 22% with this prophylaxis. The dermatological manifestations or the adverse events, acne-like rash, pruritus, post-inflammatory effects, fissure, paronychia. And here you are having a robust evidence of tetracycline drugs. The cocoon regimen, the cocoon stands for optimizing the cutaneous outcome. CO stands for the cutaneous outcome. And you are enhancing the cutaneous outcome by the cocoon dermatological management. So what it contains is minocycline or doxycycline for first 12 weeks. Following that, clindamycin, scalp ointment or scalp lotion for beyond 12 weeks. Ceramide-based moisturizers throughout the course and chlorhexidine solution on the nails. And cocoon dermatological management has reduced significantly the risk of dermatological adverse events. 76% without cocoon, 38% with cocoon. And the majority of impact has been on the cutaneous and the scalp toxicity. For the nail toxicity, the magnitude of benefit is not that great, but the majority of toxicity is more, the toxicity mitigation is more for skin and scalp. But essentially, this is the sort of the classification. Facial dermatological side effects from 62% reduced to 23%, scalp dermatological side effects 29% to 9%, and paronychia from 21% to 16%. So across the board, but the major mitigation in on skin toxicity. And this is again what we are sort of including in our patients and starting. So skip IR, dexamethasone prophylaxis as well as cocoon is something which we are recommending to our patients. So for supportive care, we talk about anticoagulation prophylaxis, we talk about dexamethasone prophylaxis and the cocoon dermatological management too. Thank you.
So the house is open for the questions. Yeah.
So, dose is 1050. That dose, most of our patients are not able to tolerate by reference. So I have five. So two of the patients, I am able to give them only 350. But luckily, they are showing the same response. I don't know what theory is that. So even 350 is as good as that much of dose, but the dose reduction was done for toxicity. So they had grade 3 loose motions, grade 3 skin toxicities. One patient though is a IFS officer. He said, "मैं तो लूंगा ही नहीं इतना." So those
So
what I
what I feel is that a lower dose might seem to work probably because essentially it has multiple mechanism of actions. It's a receptor degrader plus a bispecific signaling and an immune sort of mechanism also. But what I probably feel that no one will be able to reach 1400 per se. I think all of our patients, and we are also splitting the first dose so that the tolerance is better. So 350 and 700, day one, day two. But whether we start with a lower dose or no is a I think we de-escalate, I think, depending on the tolerance. Probably agree with Dr. Ravi. Thank you.
Thank you, sir. I request our chairperson, please felicitate our speaker with memento. For the next session on rewriting the ALK non-small cell lung cancer journey, crown at the 7th year. For this, I would like to invite Dr. Imran Nasir Sheikh sir from Mumbai. Nisar, sorry. Imran Nisar Sheikh sir from Mumbai. He is a consultant medical oncologist, Kokilaben Dhirubhai Ambani Hospital. Over to you, sir.
Good morning, everyone. Thank you, Ravi, again. I have been allotted 15 minutes, so I'll try to finish within that time. Rather than rewriting, this is a sponsored session by Pfizer. I'm going to talk about the 7-year data of use of lorlatinib in advanced and metastatic ALK positive NSCLC presented at ASCO this year. Three important considerations in this category of patients are the first line PFS is a significant contributor to patient survival, meaning a deeper and durable response with your first line therapy would probably translate into a longer survival, and that has been seen. The first line treatment also sets a trajectory for the overall outcomes because the first and second generation ALK inhibitors might not be able to cover all fusion subtypes of ALK. Around 30% of patients after progressing on the first line treatment may not be able to receive the second line because of the rapid deterioration. And as you go further down the line of treatment, the benefit goes down. Also, unique to NSCLC and to this driver mutation dependent NSCLC, we have to be vigilant about the risk of developing brain metastasis. With second generation TKIs, as many as 1 in 5 patients will develop brain metastasis. And subsequently, they have a poorer outcome with poor general health and poor overall survival. So, lorlatinib is a third generation ALK inhibitor, which has a broad spectrum of activity against almost all the known ALK resistance mutations, and it crosses the blood brain barrier, and hence it is able to meet these unmet needs. So just to go back in time a little bit, this was the Crown study design. There were around 300 patients of ALK positive advanced NSCLC, not having received any previous therapy, good performance status, stable treated or untreated brain metastasis, and at least one extracranial measurable target lesion. They were randomized 1:1 to receive lorlatinib 100 mg OD versus crizotinib. Now, crizotinib was used here because at the time of trial initiation, that was the first line therapy. And they looked at the progression free survival as the primary endpoint, and the secondary endpoints were the PFS, ORR, ICORR, ICDOR, ICTTP, OS, quality of life, and safety. No crossover was permitted. So the two arms were very well balanced. Most of them females, are equal distribution, you can say, between whites and Asians, good performance status, very few current smokers, mostly never or previous smokers, 25% patients with baseline brain metastasis, 90% patients stage 4, and around 15% patients having undergone surgery or received radiotherapy in the past. So this is the data. So at 7 years, 55% of patients on lorlatinib were alive and progression free, which is almost never seen or heard, and the median PFS has still not been reached. This is the data showing patients with and without brain metastasis. So as we have seen, without brain metastasis, again 55% at 7 years, and with brain metastasis also 53% at 7 years. Again, something unheard of. The probability of PFS events per study period, they say if you cross the first 2 years of therapy on lorlatinib, you are likely to make it till the 7 years. It was also shown to prevent and control brain metastasis. So at 7 years, look at the number, 92% of lorlatinib treated patients remain free of IC progression. And if you cross 2.5 years, no new IC progression occurred. Now, these two graphs show that at 7 years, 96% patients without baseline brain metastasis remained free of IC progression and no intracranial progression after 1.5 years. And 83% of patients with brain metastasis remained free after the of the IC progression at 7 years and no IC progression after 2.5 years. Also, lorlatinib reduces the incidence of intracranial progression as the first event as compared to crizotinib. Now, this is the depth of response. By that, we mean the maximum percentage shrinkage in the tumor size. So, at 7 years, 80% of these patients had a tumor shrinkage size of more than 50%, and 35% of patients had a tumor shrinkage size of 75%. Why is this important? Because early on, if you get this greater than 50% shrinkage in the tumor size, you are likely to be one of the long-term responders. And if you are going to be a long-term responders, which as clinicians for us is important, you need to take good care of these patients. That means make sure they remain on this drug so as to derive the maximum benefit. So that brings us to the dose modifications if required for managing adverse events. So the starting dose is usually 100 mg. You can go down to 75 as the first and 50 milligram once a day as a second dose reduction. However, it does not compromise either the intracranial or the systemic efficacy. And most of the side effects usually get resolved with these two reductions, so that at 7 years, only 5% of the patients discontinued the treatment. So this is to show you those patients who had required dose reduction within first 6 months. The PFS has not still been reached. That means there is no difference in the outcome of these patients if you reduce the dose as regards the systemic disease or the intracranial control. Safety endpoints. So proactive management of adverse events makes sure that the patient stays on these drugs for a long time and derives the maximum benefit. if you handhold these patients and put them through for the first 6 months of starting treatment, later on they do well. Some grade 3 events do occur, because of which sometimes you have to stop or discontinue the therapy, but that chance is only in 5% of the patients. No new safety signals identified and no increase in toxicity. So this is the summary of 7-year follow-up of ACE. Grade 3 and 4 side effects were 77% for Lorla versus 57% for Crizo. Those requiring dose reduction or temporary discontinuation were 64% for Lorla versus 51% for Crizo, and those requiring discontinuation were almost the same. This is the list of side effects which occur at a frequency of greater than 20% in patients receiving Lorla. As we all know, derangement in the lipid profile, edema, peripheral neuropathy, weight gain, fatigue, cognitive dysfunction, arthralgia, hypertension, dyspnea, and anemia. Lesser common ones would be diarrhea, headache, cough, pyrexia, vision disorder, liver enzyme elevation, mood effects, and back pain and constipation. So predominantly, it is the ones on the left side that one sees more in practice rather than the ones on the right side. Now, this is a timeline of when they would set in. The first month, you would generally see hypercholesterolemia. The second month, edema. Peripheral neuropathy, I haven't seen that much. Maybe one patient with some bladder dysfunction and urinary retention. Fourth month, weight gain, almost everyone. Fourth month, and cognitive dysfunction at around the 6 months. Lesser common side effects would sometimes include mood dysfunction and psychotic event effects during the second month and speech defects. However, the good news is it's less than 5% of cases. So some patient on lorlatinib, preferably so, or rather more commonly so, presents to you with brain metastasis and presents to you with some mood defects. Please don't take it lightly. Keep in mind that this could also be lorlatinib causing this. However, with effective therapy management, patients were able to remain on long-term treatment and less or no likelihood of discontinuation after you pass first 2 years of treatment. How do we manage? As we do with all other patients, prepare the patient and caregiver, let them know what to expect, monitor at baseline and each follow-up visit for your lipid profile, blood pressure, and other parameters. Manage at the first sign of toxicity with appropriate dose stoppage or reduction, and then reassess at subsequent visit to re-challenge, maybe at the same dose or maybe at a reduced dose. So, how to manage hyperlipidemia? Usually, you do a baseline lipid profile and at each follow-up, if it's on the higher side, the cholesterol and the triglycerides start with rosuvastatin 5 mg. That is the basic dose. You can go up to 40 mg a day. However, if it is still not responding, you might add ezetimibe. Or if the hypertriglyceridemia is there, you can think of adding fibrates. In rare incidents that patient is not monitored and presents to you with a life-threatening high level of cholesterol and triglyceride, please stop the drug. Let it come down to normal, cholesterol less than 400, triglycerides less than 500. Restart maybe with one lower level, that is from 100 to 75, or if it's 75, then 50. The other toxicities are usually very well managed with some lifestyle modifications, weight gain, edema, peripheral neuropathy. But the CNS side effects can really be sometimes troubling. We had some patients with psychotic effects, irrelevant talks during the first 6 months of therapy. And one has to be vigilant about that. Sometimes it could be as subtle as just heaviness of the head. So we have seen all the spectrum of CNS side effects. And if they are there and you correlate it with your therapy, please stop and then reduce it by 25 milligram. So to summarize, lorlatinib delivers the longest PFS ever reported in lung cancer. At 7 years, 55% of patients are alive, as compared to only 3% with crizotinib. At 7 years, it provides the best or most durable control of brain metastasis and prevents development of new brain metastasis. So 92% of these patients do not progress versus 16% with crizotinib. And proactive management of the side effects would lead to lesser discontinuation rates, as has been seen in this trial setting, only 5%, and they do not interfere with your overall outcome. No new safety signals were seen. So that's the end of my talk. Hopefully, it's in time.
Thank you so much. Any questions for the house, or we'll conclude this session?
So Bilai sir, previously we were discussing about mutations. So this is one such mutation we as a medical oncologist love to treat because this drug, like Dr. Imran has presented. So now we have a person who is surviving 7 years. So we have 7 years data, and still the trial is ongoing. Patient have not even progressed. So there are not all mutations are like that, but this is one such story and one such drug. Thank you. Yeah.
And that's in presence of the brain metastasis also. So somebody living for 7 years with a disease which would have killed at 6 months is really commendable. Thank you.
Thank you, sir. Thank you, sir. I request our chairpersons, please felicitate a memento to our speaker. And I request our chairpersons, along with Dr. Dipesh Maske, sir, please collect their mementos from the. Please join, sir. Dr. Dipesh, please join. I request our chairpersons, please collect their mementos from the memento podium, which is just outside of the hall. And I request Dr. Naveen Jain, please felicitate our chairpersons with the mementos. Now we move to the next session. We have Dr. Deba Dulal Visbas from Raipur with his talk on serplulimab in perioperative gastric cancers. For this, I would like to invite Dr. K.R. Sinha from Rajim to chair the session. I invite Dr. Manish from AIMS, Dr. Shruti Rao, and Dr. Dilpreet Gurdatta. Please join the dais as a chairperson. Over to you, sir.
Good morning. So this is a tongue twister immunotherapy, serplulimab, and marketed in India is heteronifly. So I will just summarize the thing that this is just on 1st of June. This has come up in Lancet as well as ESCO, presented in ESCO, about the perioperative serplulimab in neoadjuvant chemotherapy for PDL1 positive. They took it as more than equal to 5% PDL1, randomized double-blind multicenter study, and this was done in Asia, specifically Chinese group they have done. Background is 60% of all gastric cancer occur in Eastern. So these are the background. So they took SOX. SOX is S1 plus oxaliplatin. And they compared, or the conventionally, there are two other trials are there. One is Keynote 585, and that was a negative trial. And Metenhon, that used durvalumab as the IO agent, and that was showing benefit, positive trial. So this is Estrom 006 phase 3 trial, just recently presented in ESCO. So Keynote 858, so that was a negative arm. So I'm not talking in detail, but they took pembrolizumab plus the chemotherapy arm was Folfox or Capox or Flot. The paths here was double, but there was less of uh, OS data. So this was regarded as negative trial, and pathological complete response was better, but event-free survival was not positive. That's why this is a negative trial, and this is not a hazard ratio is 0.81%. No statistical significance. No statistical significance. Summary and conclusion is that final Keynote 858 is a did not succeed in improving EFS in perioperative gastric cancer. Matterhorn, this is please note this is a positive trial. Durvalumab 1500 mg every month or every 28 days plus Flot compared to, and the this was perioperative, 2 cycles before surgery and total 12 cycles after surgery. The path CR was better compared to only chemotherapy arm, 7% versus 19%, and the event-free survival was better, and overall hazard ratio was 0.71. Median EFS is not reached yet. Second endpoint overall survival was also hazard ratio is 0.78. Now come to this serplulimab trial. This is phase 3 study. Serplulimab plus they have please note that FLOT was not used. Only they used the Chinese people. They love using S1 with oxaliplatin, not FLOT, not Folfox, not Capox. So they use S1 plus oxaliplatin 3 cycles before, and post surgery there is no chemotherapy arm. Only serplulimab was used for 17 cycles versus 3 cycles of SOX, surgery, then 5 cycles of SOX. So the arms were matched. The characteristics were also matched. Please note, females were only 20%, males highest number. Then gastric cancer was 90%, G junction adenocarcinoma was 10% around, T3, T4 were 60%, whereas maternal T4 was 28%. So T4 component were more. Also, there is a arm where they have compared with H. pylori infection. So H. pylori was 60% on both arms. And if H. pylori is there, then there is a good response. PDL1 was taken as 5%, less than 5% or more than 5 to 50% or more than 50%. There is no arm containing negative PDL1. So the pathological CR was 6% versus 21%. And you will be surprised that the investigators arm, they suggested the hazard ratio of 0.73, whereas the blinded arm, blinded independent review committee, they said that the stratified hazard ratio is 0.67. So the blinded committee, they said that it is far better working compared to investigators' conclusion. So this is the A, and the negative point was shown in the female arm because only female population, because the number were less. So we cannot exactly say whether it is not working. H. pylori, you can see it is working well. CPS score, if it is more, then it is working a little better. More than 65 here is little less, or that may be due to yeah. Also, PS is 0 is working better. So drug exposure is, you will please note that the chemotherapy were used only 3 times, SOX 3 times, whereas in the placebo arm it was 8 times chemotherapy. So there is a very less exposure of. So this is a courageous trial where they have omitted the conventional Folfox, Capox or FLOT, and also they have not added any adjuvant chemotherapy here. That is a great thing. So adverse events, you might be wondering that what was the adverse events even after 20 cycles of serplulimab. You see this last this one related to death related to serplulimab or placebo was 0.7. Related to SOX or immunotherapy was 0.7. Related to any study treatment was 0.7. Other deaths were not related. That was 5.1%, but they were not related to serplulimab or chemotherapy. And immune-related adverse events of any grade was the only one, that is 6.2%. Grade 3 or worse is 6.2% only. So that is means doable. Conclusion is, this slide is important. So significantly improved primary endpoint. Median survival is not reached yet versus 39.9 months. Hazard ratio is 0.73. Investigators arm. And when that was blinded committee review, they said that it is hazard ratio is 0.67. So 0.06% further better. Path CR was 21% versus 6%. Tolerability was good. Grade 3 or more side effects were less in the immunotherapy arm compared to chemotherapy arm. That is one cause because in chemotherapy arm, in placebo arm, there were 8 chemotherapies, and in experimental arm, there were only 3 chemotherapies. And the last one you can see treatment related discontinuation. Treatment related discontinuation was in the experimental arm, it was 6.5% compared to 10.5% in the standard arm. So this finding suggests regimen has a potential to become first chemotherapy sparing adjuvant approach of neoadjuvant immunotherapy plus chemotherapy. This was published on the same day of its presentation at ESCO in the main Lancet journal. And first perioperative study to demonstrate an adjuvant chemotherapy sparing surgery a strategy following neoadjuvant chemotherapy plus immunotherapy. The regimen demonstrated robust efficacy with a significant benefit in primary endpoint and consistent improved across secondary endpoints compared with perioperative chemotherapy. This approach showed better tolerability with more favorable safety side profile. This is the paths here you can compare with Matterhorn. Matterhorn showed 7 versus 19. Here it is shows 6% versus 22%. So it is probably better. And event-free survival, Astrom has shown this one. Hazard ratio is 0.7. Matterhorn hazard ratio is 0.71. Here it is 0.73. But Astrom blinded committee review is 0.67. So it is better. So this one. And conclusion is Astrom 0.006 is a positive phase 3 trial showing benefit of Serplulimab plus SOX. And I assume, or can I have the guesswork that if we use FLOT 4 cycles before surgery, might be it will result in better paths here, especially in young and fit patients. Serplulimab is the first anti-PD-L1 to show improvement in perioperative gastric cancer. Serplulimab has better tolerability compared to chemo, and this presents the first such approach of chemo sparing in the adjuvant setting. Thank you.
Thank you, sir.
Question.
I request our chairpersons, please felicitate our speaker with
Miss
momentum.
will now trap me. Sneha.
So one
Okay. Quick.
new adjuvant socks plus this versus flot plus Durva. Which one?
This one. So in Durba, they took irrespective of PDL1, but the actual trial says that 90% were positive, PDL1 positive, and 10% were negative. Hazard ratio is 0.71 versus 0.67, and that took 8 cycles of flot in Matterhorn. Here only 3 cycles of SOX, and that there was no adjuvant chemotherapy. So it is either non-inferior, or if you want, you can say it is superior.
So these are all the observations we have been making for Chinese manufactured immunotherapy.
Yeah.
Sometimes you see the results, you feel they are too good to be true. The Keynote 585 failure was classically attributed to FLOT. They did not use the FLOT backbone, they used cisplatin 5FU. Here in Serplulimab, only 3 cycles of SOS. The only thing they selected only PDL1. To answer Sneha's question, if it is PDL1 negative, we have a approval only for Matterhorn, right?
Sure.
So we should use there.
Sure.
My point is, I personally believe Keynote 585 also would have been positive
Sure.
if the alpha allocation would have been better. There are a lot of criticism about their trial design. There was no alpha allocation to OS at all. And that's the reason probably did not reach the statistical significance. But if you see the number 44 versus 26, 20 months of EFS benefit is there. So I feel all immunotherapy added to chemotherapy should be the way to go forward for G junction and
Agree, sir.
I believe all three were
Agree.
positive.
Agree.
Yeah.
Thank you, sir. Thank you, sir.
Thank you, sir. I request our chairpersons, please felicitate our speaker with a memento. And for the next session, I would like to invite chairpersons Dr. Rajen Parghania sir, Dr. Raka Shivhare, Dr. Sanjay Verma, Dr. Ajay Govardhan sir. Please join the dais. And Dr. Divakar sir from for Ranjangaon, Dr. Deepak Jaiswal. For the next session, I would like to invite Dr. Siddharth Tamaskar. He is senior consultant, robotic surgeon, HOD Ramakrishna Care Hospital, Raipur. He will be delivering his talk on state of art robotic surgery, precision without compromise. Over to you.
Yes, it gives me immense pleasure to share this dais, which I don't deserve, I think. But the point is that Dr. Tamaskar, Dr. Dave, Dr. Mauroy, they are all known to me, and I am known to them. They're more important since decades. So, without wasting time, I will request Dr. Tamaskar to start his presentation on robotic surgery.
Very good afternoon, sir, and thank you. First of all, I was just sitting here for the last 2 hours listening to so many things which I could not understand a single line. And it reiterated my fact that why I became a surgeon. So surgeons are more man of actions, and I am a man of action. And for disclaimers first, I'm not an oncosurgeon. Number two, that this all the work that I'm showing has been done in the Department of Surgery headed by Dr. Sandeep Dave. And we have been privileged to be a little bit well accomplished in doing something. That is why we are showing you this. I'm not a propagand of anything. And of course, I will only be showing the Da Vinci platform because that is where I've been trained on that. And I just acknowledge Dr. Vikram Sharma for helping me in this preparing this lecture. So my lecture is not too much of a technical talk. It is just going to show you what is possible by robotics and why robotics. Why should you go for robotics? Why minimally invasive? So I first start with the line that when a patient comes to you and when the patient is advised surgery for anything, the first thing that the patient asks you is, can this be done by minimal access? क्या इसको लेजर से कर सकते हैं? That is what the patient asks you. So that is what he means by minimal access. So I'm a minimal access surgeon. So obviously, minimal access, it has to preserve the principles of radical cancer resection. So any surgery that does not preserve the principles cannot be applied. That's for sure. So obviously, what we had as a limitation of laparoscopic surgery initially were the rigid instruments, the two-dimensional monitor interfaces. But right now, we also have a three-dimensional monitor interface, and that takes away that thing also. And definitely the loss of haptic feedback and natural hand tremor amplification. There are certain barriers when you're operating on the abdomen and thorax. That is what I call as the bone barriers, especially the deep pelvis barrier for surgeries, low down in the pelvis, for example, the lower rectal cancers or gynecological cancers. And also for disclaimers, I'm not a gynecologist, but I'll be showing you gynecological surgery also. So the robotic resolution, it melds the minimal access recovery benefits with open surgery visualization, precision, and complete structural articulation. So we have to have an equivalent or superior R0 margins for those who are not surgeons. Obviously, the oncologists may understand, but a lot of in the population, R0 means that you've completely removed the tumor and not compromised on any of the principles. So it has to be a substantiative reduction in the perioperative inflammatory stress markers and shorter times to initiate crucial adjuvant systemic therapy. So it gives you a better recovery time. That is what we want. So it has a 3D HD visualization. It has endoris dexterity. So it offers you at least 7 degrees of motion to do things that which are not possible by the human hand actually. And of course, It acts as an able assistant for prolonged surgeries. Imagine operating for 8 hours, your assistants are there in the Whipples for 8 hours. So let us talk about only, I'll be, because it's a very vast topic and because of the lack of time, I'll be only covering a few of the malignancies. So let us talk about the robotic standards is esophageal, gastric, and pancreatic, what I have labeled as upper GI malignancies. So D2 lymphadenectomy is the global benchmark for advanced resectable gastric adeno-CS. And the robotic advantage is the intuitive tissue retraction. It allows the clear visualization. Lymph node harvesting is one of the major benefits with robotics. And we have this landmark class 2 trial, which showed a 98% R0 resection rate. So this multi-center trial, the confirmed the non-inferiority of the laparoscopic approach. It did not label it as superior, but it has said that it is at least equivalent to open surgery. Then if you can see the extended T2 lymph node harvests we have, the best harvests were with the robotic gastrectomy. But if you can compare the operating time, definitely the operating time would be more with the robot. But still we are getting there, we are getting more and more, we are getting better, we are getting faster with it. And just to show you, I don't want to, because these are all long videos, I'll just show you what is possible. So this is a female with a distal CA stomach and adeno CA. This is how you are doing the whole of the omentectomy. And then you will proceed to do all the station lymph nodes. I'll just be forwarding the video, sorry. You may just find it as an intermittent interruption to your, sorry. And then when we talk about what it offers, basically, see if you can appreciate what is needed with D2 gastrectomies, you have to take out all the station of lymph nodes, all the precision which is required there is offered there. There you have the right gastroeploic vein which we show right now. Then the next I would like to show you, I'm just forwarding this. When we are doing the transection of the duodenum, that is what we do to separate the stomach. You have what is called the staplers, which is the sure form stapler which is available, and it has extensive movements which are possible. That is the stapler which is used, and that stapler is AI enabled, and you can assess all the thickness of the tissue and you can fire it and take it out. Of course, we'll go ahead with uh, dissecting the different lymph nodes. You have to harvest all the lymph nodes, and this is how you've cleared up all the structures which are there. Sorry, I'm just forwarding it, and I'm just showing it at the end what I feel is what is appropriate for this is to show how we are anastomosing after we are resecting the stomach. What we are going to do is we are going to anastomose a loop of jejunum. If you can appreciate, this is the loop of jejunum, and that is what we are going to anastomose, and that is the transected esophagus. So we are doing a hand sewn, what is called as a hand sewn. We're doing it with the hand. That is the esophagojejunostomy, and we're putting a Ryle's tube just as a maybe a stent or just for the feeding purpose. So that precision which is provided by the robo is of another kind. You have to feel it to believe it. So let's come to pancreatic cancers. Whipple's procedure is the anybody who does Whipple's is says that I'm the best surgeon in the world because I'm able to do Whipple's. Is an extensive procedure which involves critical vascular proximity, technical intricate anastomosis like pancreaticojejunostomy, choledochojejunostomy, and obviously the gastrojejunostomy. So open surgery, open Whipples involves large subcostal incisions. The robotic approach gets you extensive high magnification, and the delicate pancreatic duct and extra needle placements can be done there. Again, we have a very good trial that was a Diploma 2 trial where we have a 90% oncology safety yield, and it validates the minimal invasive Whipples approach. Anybody can question why would you want to do a Whipples by minimal invasive when you need to extract a big specimen and all that, but you have to see the patient to understand what you're doing. And of course, the reducing the pancreatic fistula leaks. What we are scared of is the leaks after the surgery. So there's a clinical relevant post-operative outcome, and the reconstruction quality is much, much better with the robotic approach. Just to show you some part of this robotic Whipple's procedure, that is how we start dissecting the division of the gastrocolic omentum. Again, I'm going to forward this because it's a big video, and I'll be just that is the plane between the neck of the pancreas and the vein. That's what we call the tunnel of love. So that helps you separate these structures. That's the cockerization of the duodenum that we're doing. That is mobilizing the whole duodenum. Then again, here of course we have we have taken assistance of a stapler where you can have your assistant doing that for you. Sometimes you need to uh, have extra ports and all those things for that. I'll just move ahead and I'll show you what the actual advantage is. That is the common hepatic which is separated. That incidentally is the energy source which is available with the Da Vinci robot. There is the pericholedochal lymph node dissection, right gastric artery. There you can appreciate that's the gallbladder and we're trying to dissect off the bile duct. So after that, there you can see that is the portal vein. That is the bile duct, the portal vein. The important structures we separated. And at the end, I'll just show you what is the exact advantage when we are doing the reconstruction. Of course, we are resecting it, and ultimately, what we will do that is the mucosa to mucosa pancreatic or jejunostomy, where you're anastomosing the pancreas with the jejunum to maintain the continuity of the pancreatic flow. And ultimately, the again another anastomosis is the choledochojejunostomy. That is, we are anastomosing the bile duct with the jejunum. So these are the precision things which are offered by the robo. Again, another field where we do a lot of surgery is the total mesorectal excision for colorectal cancers. We have an avascular plane dissection. Autonomic nerve preservation is one of the very important things because most of the patients otherwise will develop sexual and this bowel bladder dysfunctions. And especially in obese and male pelvis, the rigid laparoscopy instruments struggle during the surgery. So we have the ROLAR trial, which had a less than 5% open conversion, and they had implications for the narrow pelvis in the first major international multicenter RCT comparing robotic versus laparoscopic cancer rectal surgery, and it demonstrated the value of mechanical articulation in anatomically complex cohorts. Again, we have the real trial, which is a 3-year outcomes for the prospective multicenter real trial. And you have unmatched stability of the robotic platform in performing deep rectal mobilization, high definition camera, and decreased friction to do this. Robot sparing advantage, the functional autonomic preservation, surgically validated questionnaires confirm much faster recovery of bladder and erectile functions in all these patients. Of course, you have I'll take another 1 or 2 minutes. I'm sorry, with your permission. So just to show you, I'll just show you, see, you have to mobilize, if you can understand from the left upper part of the abdomen, you have to mobilize the whole colon, that is, you have to mobilize from the spleen up to the pelvis. And you are able to do it with the robot by docking the robot in such a way that you're able to mobilize it. And just I'll show, of course, I've shown a lot of dissection and all these things. Just show you the use of what is called as the ICG or the dye to ascertain how the viability of the anastomosis is confirmed. So those advantages, of course, nowadays we also have on the 2D platforms also. But here I'm just showing it with a robo. After we are resected and when we are doing the anastomosis, what we will be doing is we are putting in the dye. That is the resection. We've transected the rectum, and during the anastomosis, that is how we put in the ICG dye, and we have a switch which is called as the firefly mode, and you can assess the vascularity of the anastomosis and the viability of the anastomosis. Another advantage which is offered. Gynecological malignancy, again, just to show endometrial cancer remains the most prevalent cancer. The minimal axis is ideal for obesity and sentinel lymph node mapping. Again, that is what is shown to the right of the screen is what we call as the ICG installation for doing the sentinel lymph node mapping. We have the paradigm shifting FIRES trial, which has an SLN negative predictive value of 97%, replacing the pelvic lymphadenectomy if you do a sentinel lymph node biopsy. Here I have a video of radical. I'm just skipping it. We do robotic radical hysterectomies, commonly patients being referred to us, and that is the central lymph node. Just I wanted to show you, and then we send it for a frozen section. If it is positive, then only we'll go ahead with a complete lymphadenectomy, or we don't need to do it. So again, surgical protocols must guarantee oncological safety. That is the most important thing. The parametrial clearance and the ureteric ureteric tunneling, which are two of the most important steps during the surgery, are taken care of very well. And of course, the 3-year disease-free survival, the impact of the LSCC trial, but yeah. So this trial, it shows that for cancers of the cervix, the preferred method is open surgery. That is what I just wanted to emphasize here. So of course, when you're going to your robotic program, you will go to the simulation phase, then you go to the proctored stage, then you reach a surgical plateau, and then you have the continuous mastery. So that is how you're going to move ahead in your platform. Of course, the key takeaways are that clinical trial evidence confirms that robotic oncology resections are safe and effective, but proper patient selection, standardized no-touch techniques, and formal learning pathways are vital for optimizing the surgery. Thank you so much. I hope I have done justice to the topic. Thank you.
If there are any questions from the house, otherwise I have got three questions.
Yes, sir.
One is all of us know that the laparoscopic ripples used to take 6 to 8 hours time.
Yeah.
It was started by Professor C. Valani Velu of Coimbatore. How much time we take now with this?
Similar, sir. Similar times.
Similar time. So a time constant is not much changed.
No.
Dexterity of instruments, 360-degree rotation is the most important.
Yeah. So that is why I said
That you have told already.
just said the advantages is the anastomosis.
Yeah.
The advantage is the leak rates. The advantage is not the time. The advantage is people will question why do you want to do a minimal invasive robotic or a robotic for a Whipples when it is going to take 8 hours for you to do. But understand that you've taken out the specimen to a fen and steel incision. In an open surgery, you've gone a subcostal bilateral, you have a bucket handle incision, all those things, which I don't want to go into technical details. You can understand the morbidity of the patients, which can be different. But definitely, I'm not a propaganda of minimal invasive surgery for Whipples. This I'm just showing you that it is possible to do it.
Radicality is assured means
Yes, absolutely. So if radicality is not assured, I don't think we can propagate that method.
you take out the specimens like the one in which you perform, FNS incision.
Yeah, we put it in an endo bag, and obviously the
And
protocols.
what about the final ergonomic status of your body when you perform a lap surgery and you do a robotic lap surgery? The advantage to you
Yeah, so
as a surgeon.
of course, that I've not emphasized. As a surgeon, that is the biggest advantage because you're standing there for 6 to 8 hours. But ultimately, your surgical team is there for you. So they are standing there, but the surgeon is, of course, at a comfort because he's sitting in the console all the time.
That's nice. Thank you so much.
Thank you, sir.
Nice presentation.
Thank you, sir. I request our chairpersons, please felicitate our speaker with memento.
Endometrial cancer.
Chemotherapy backbone, which was paclitaxel and carboplatin AUC 5. And arm B contained tislelizumab combined with nab-paclitaxel along with carboplatin. And arm C was only the chemotherapy alone, which was standard of care. And the primary endpoint was PFS as assessed by independent review committee, and overall survival was a secondary endpoint. So by the Kaplan-Meier graph, we can see here that both the tislelizumab containing arms did better than the chemotherapy alone arm. and both arms showed over 50% reduction in the risk of progression or death. In the subgroup analysis also, we can see that all the subgroups showed benefit with the addition of tislelizumab, and it was irrespective of the PD-L1 expression. For all the PD-L1 expression levels, be it less than 1, there was benefit with the tislelizumab addition. And the overall response rate were also high, more than 70% in both arm A and B, which contained tislelizumab. And overall response rate was around 50% with the chemotherapy alone arm. And median overall survival also was higher in the arm A and B, which contained tislelizumab. In arm A, it was 26 months. In arm B, it was 23 months, compared to 14 months in arm C, which was chemotherapy alone arm. So conclusion from Rational 3007 trial is that tislelizumab plus chemotherapy provides sustained 4-year survival benefit, broad subgroup efficacy, and a consistent safety profile in the first-line advanced squamous NSCLC. So ideally, this should not be done, but this table compares the median overall survival data from various clinical trials of various anti-PD-1 receptors available. So numerically, it was highest. The median overall survival was highest with the tislelizumab of 26 months. Second trial is Rational 304, which was done in non-squamous NSCLC in first line. It compared tislelizumab plus chemotherapy versus chemotherapy alone, and it contained arm A and B. Arm A was tislelizumab along with the standard of care chemotherapy, which was platinum chemotherapy, either cisplatin or carboplatin combined with pemetrexed. And the arm B contained only the standard of care chemotherapy. And both were followed by maintenance phase. And in the arm A, maintenance was tislelizumab plus pemetrexed given every 3 weekly. And in the chemo alone arm, the maintenance was pemetrexed alone in the at 3 weekly interval. And the primary endpoint was PFS as assessed by independent review committee. Overall survival was secondary endpoint. From this Kaplan-Meier graph, we can see that addition of tislelizumab to chemotherapy led to significant reduction in the risk of progression or death of that, which was around 37%. Overall response rate was also better with the arm A, which was 57%, and around 36% in the chemotherapy alone arm. And the median overall survival was 21.6 months in arm A and 14.9 months in arm B. And the hazard ratio was 0.68. Notch 1 4 mutation showed potential association with better tislelizumab efficacy, which was correlated with both overall survival and progression-free survival. Again, a similar table which showed that in second line NSCLC, irrespective of histology, the median overall survival was numerically higher at 16.9 months with tislelizumab. This was a systematic literature review and meta-analysis published last year of tislelizumab versus other anti-PD-1 or PD-L1 agents in first and subsequent line in locally advanced or metastatic NSCLC. In squamous variant in first line, this meta-analysis showed for PFS that tislelizumab plus chemotherapy was significantly more favorable than nivolumab monotherapy, atezolizumab plus chemotherapy, or nivolumab plus chemotherapy, or nivolumab plus ipilimumab. And in non-squamous variant for in the first line, this meta-analysis showed that PFS was better in tislelizumab plus chemotherapy arm compared to other PD-1 inhibitors, and it was ranked as the most efficacious treatment according to this meta-analysis. And also in the second line and subsequent NSCLC of any histology for PFS, tislelizumab monotherapy was ranked as the most efficacious treatment. So tislelizumab is a highly active and efficacious PD-1 inhibitor. We can see from the network meta-analysis. And tislelizumab monotherapy in second line and subsequent line for NSCLC, and tislelizumab plus chemotherapy in first line squamous and non-squamous variant with PD-L1 expression more than 50% was found to be comparable to or more favorable than other anti-PD-1 therapies with regards to OS, PFS, and treatment-related adverse events. Tislelizumab has been also trialed in other lung cancer setting, like in neoadjuvant and adjuvant setting also.
And this is the only PD-1 inhibitor with comprehensive benefit from late to early stage and across both non-small and small cell lung cancer variants. So this study is a rational 312, which was conducted in an extensive stage small cell lung cancer. It was in the first line setting. And this compared tislelizumab combined with carboplatin or cisplatin with etoposide. And the comparator arm was the chemotherapy alone arm. And the tislelizumab arm was followed by maintenance with the tislelizumab. And in the chemo alone arm, it was followed by maintenance with placebo. And the primary endpoint was overall survival here. The baseline characteristics were well balanced in both the subgroups. From this graph, we can see that overall survival in the intention to treat population was better with the tislelizumab arm at the median overall survival of 15.5 months compared to 13.5 months in the chemotherapy alone arm. And 3-year overall survival rate was also more in the tislelizumab group at 22% versus 13% in the chemo alone arm. In the subgroup analysis, we can see that all the subgroups were benefited with the addition of tislelizumab, irrespective of the PDL1 expression. And regarding safety, overall safety profile was consistent with the known risk of each treatment component, and no new safety signals were detected. So tislelizumab plus chemotherapy demonstrated a stable, predictable, and manageable long-term safety profile with no new toxicity signals. We can see here that grade 3 or more treatment-related adverse events was 89% in the tislelizumab arm and 90% in the chemotherapy alone arm. And however, the death rates were more in the tislelizumab arm at 6% compared to around 2% in the chemotherapy arm, which is true with other anti-PD-1 inhibitors also. So, in conclusion of rational 312 trial, it showed a long-term follow-up efficacy and clinically meaningful and durable overall survival benefit with addition of tislelizumab to the chemotherapy in the first line for even the extensive stage small cell lung cancer. Okay, so to summarize the results of the trials, in the first line squamous NSCLC, tislelizumab plus paclitaxel or nab-paclitaxel and carboplatin show a statistically significant improvement in tumor progression and response as compared to paclitaxel and carboplatin alone. And also in the first line in non-squamous setting, the tislelizumab in combination with chemo resulted in significantly longer survival benefit and tumor response in patients with PDL1 more than or 50% expression. Regarding safety, we have already seen that it is the safety is comparable and manageable, and it also has a flexible dosing of 150 milligrams every 2 weeks, or 200 milligrams every 3 weeks, or 300 milligrams every 4 weeks, as approved in US. And thank you for kind listening.
Any questions for the audience are invited?
Yes.
No question. Thank you, Doctor.
I request our chairpersons, please felicitate speaker with the memento, and I request Dr. Ravi Jaiswal, please join.
Please felicitate. आप बीच में आ जाओ हाँ बस हाँ तो सर आप आ जाओ दीपक सर ठीक
And for the further felicitation of our chairpersons, I request Dr. Siddhartha Maskar, please give mementos to our chairperson at Momentidas, which is just outside of the hall. Now we move to our next session on hematological malignancies. For this, we have a panel discussion. Moderator of this session is Dr. Rayaz Ahmad. He is a vice president, vice chairman, hematology and bone marrow transplant, Max Super Specialty Hospital, Saket, Delhi. And the chairpersons are Dr. Sanjeev Anand Kale, sir. He is a senior consultant nephrologist at Ramakrishna Care Hospital, Raipur. Dr. Nilesh Jain from Raipur. Dr. Varun Agrawal from Raipur. Dr. Vinay Rathor from Raipur. Dr. Krishna Somani, Raipur, Dr. Ramesh Sahu from Raipur, Dr. Priya Pathak from AIMS, Raipur, Dr. Parvati Joshi from Raipur. And our panelists are Dr. Dibendu De from Raipur, Dr. Vikas Goyal, hematologist from Raipur, Dr. Ankit Sahai, he's a hematologist from Raipur, Dr. Rajesh Agrawal, oncopathologist from Raipur, Dr. Mukesh Sharma, hematologist from Raipur, Dr. Sunil Chopde, Sir Mumbai, and Dr. Annapurna Rai from Raipur. I request Dr.
Rohan Tiwani from Hyderabad, Basau Tarkam Indo-American to join as a panelist.
Over to you, sir.
Thank you. Thank you, organizers, for having me here as a moderator. So my role is to moderate the session on multiple myeloma, and I have got a good panelist here. So few things on multiple myeloma we'll like to discuss here. We have been practicing multiple myeloma. Newer things, as in any other organ of oncology, multiple myeloma has also evolved from the days of dexamethasone, thalidomide to now bispecifics. So what has changed really in our practice? Let's see from the beginning. Okay, so this is just a hypothetical case scenario. A 54-year-old male complaining of fatigue and backache, and the labs which were done showed the CBC anemia of 8.9, creatinine normal, calcium elevated, LFT's total protein high, albumin low, with SGOT, SGPT being normal, alphos normal, LDH 234 within normal range, beta 2M 4.5, M spike of 4.2, kappa lambda, kappa being raised in more than 1200. The bone marrow then shows 50% plasma cells, and the fish has got both 13Q and 1Q gain. And the PET scan done had showed fracture at T11 level. That was the reason of the pain. So this is the hypothetical case which we get commonly. So we know in the presence of this 1Q gain, it's a high risk multiple myeloma you are going to treat and indications. So we will start before you do. So how important is to do a fish analysis, and how it's commonly at the tier 2, tier 3 level when we are practicing the fish analysis. Anybody can take questions. You understood my question? Yeah. So in treatment of multiple myeloma, we have been treating multiple myeloma. Why fish is important? To do fish test in each and every case. Try to do fish in every case. How does it impact? Any of us?
So, sir, we do fish test from the bone marrow and the cytogenetics and fish. These are the main nowadays to classify the patient into either standard risk or high risk. There are certain high risk cytogenetic changes like 414, 1416, 1420, 1Q gain, 17P. So, because the treatment we have to decide if the patient is of high risk, then the treatment plan of treatment is different. And if the patient is of standard risk, then plan of treatment is different. So at the baseline, we must do fish test to categorize the patient.
Sure. Thanks, Vikas. Okay, so from the lab, I think so two doctors are available. Dr. Rajesh is here. Yeah, Dr. Rajesh. So why can't we do? You say we have been listening to the lot of minimal invasive. So can we do fish from the peripheral blood?
Sample from the peripheral blood, but the bone marrow is quite good as per the cellularity is concerned.
So fish, doctor, means generally we do send from the bone marrow.
Yeah.
The question was why not peripheral blood? Why only you need a marrow sample?
Marrow sample is good because and plasma cell in the peripheral blood is sometimes in some cases are seen, in not in all cases. That's why.
Right. So generally the plasma cells, it's generally in the bone marrow. We don't see in the peripheral blood, only if it is very few. So when we send fish sample, we are doing the plasma cell sorting. First, you have to do the plasma cell sorting, then you do the fish analysis. So all the clinicians, so like cytogenetics that we use to send from the peripheral blood, it's not equivalent to the what we send from the bone marrow. So the fish sample in multiple myeloma has to be sent from the bone marrow, not from the peripheral blood. That's what we know because we do the plasma cell sorting. So even if you have got the dilute sample, when you do the aspirate and you don't have those percentage of plasma cells, the probability that you are not getting any fish samples are high if you don't have that plasma cell percentages. So we have to interpret that fish being negative in the absence of too many plasma cells in the aspirate report, because you always get the myeloma involvement is in a patchy form of cells. It's not that a uniform is there. So you where your needle is hitting, that the site from where you're aspirating the marrow may not be involved. That patch may not be involved. So that part may be diluted. Biopsy may pick up, but then you have to correlate that your fish report, because as we were discussing, Dr. Vikas said that the prognostication of myeloma depends heavily on the fish, whether it is low risk and high risk. Okay. So before we consider what all, Debandu, you can take this day. What factors do you consider while having that starting the treatment of multiple myeloma?
So for any patients of multiple myeloma, when we go for choice of therapy, so we consider the different criteria regarding the patient factors, the disease-related factors, and the obviously the treatment factors. So the patient-related factors, mostly the comorbidities that the patient is having, and also the patient's disease burden. And regarding the disease-related factors, what are the different organ involvements before the start of the therapy, and also the cytogenetic and phase profiles according to the risk stratifications. So accordingly, we to consider what will be the treatment choice, and we divide the patients generally first in the high risk group or low risk group, and secondly whether they are transplant eligible or transplant ineligible, and accordingly we plan our treatment. Mostly we start with triplets. Nobody does a doublet right now, and we also try to use some of the other target therapy like daratumumab in the first line, especially in patients with a high risk.
Sure. Thanks, Debandu. So Dr. Mukesh is there. Yeah. So, Dr. Mukesh, so next question you can take. What are the goals when you are trying to induce the patient? Once you have diagnosed, you have staged, you have fished, you know this is high risk myeloma, transplant eligible or transplant ineligible. You have decided, and then okay, say. So, when you decide a therapy, whether you are using triplet therapy or quadruplet therapy, what do you think? What this induction therapy is going to do with my patient? What are their goals of induction therapy? What mean to say?
So for any management, you have to decide, as Dr. Devendra said, what is your plan, whether patient is transplant eligible or transplant ineligible, and whether it's a high risk or standard risk. With high risk, we have to go for quadruplet regimen now with the standard of care, and with standard we can follow with triple regimen. For any induction therapy, we have main is you have to reduce the disease burden, and patients suffering from any CRAB features complication, that has to be respond to the treatment also. Along with, we have to achieve the remissions, and after achieving our, if patient is young and transplant eligible, we have to preserve for the stem cells also.
Okay, Dr. Rajesh.
I'm Dr. Rohan, sir.
Oh, sorry, Dr. Rohan. I'm sorry.
Right. So already has been said very nicely by sir. One is same, whatever symptoms were there, is the symptom reduction occurring or not. That's what our goal of induction therapy will be. Response, no doubt, everybody would wish for MRD negativity, but at least just it's to monitor the patient so that at least we can take the patient for transplant if the patient is transplant eligible. If transplant ineligible, the goal is to maintain quality of life plus symptom reduction, maintaining a good PFS till as long as possible for the patient.
So you use the word MRD negativity. So how important do you think, this question will come again? So when you start the therapy, do you counsel the patient that okay, we are going to have MRD negative status?
No, sir, not for all the patients because probably that adds to the worry if you are not able to achieve MRD negativity. But I think at least VGPR or more than VGPR is what I would be looking into.
Sure. So this was all discussed. We patient related, disease related, or treatment related. conditions you must think. It's not that everyone goes into the things. Okay, the quadruplet has been like we in India, our issues are different. We have a different set of patients, but of late the quadruplet has been the standard of choice. That quadruplet have to be used whether it is standard risk or high risk, and given the 3 to 4 cycles, then you go, if you achieve PR or VGPR or CR, go for transplant, followed by the consolidation, followed by maintenance therapy. But those who are not transplant eligible, yes, at least 9 to 12 cycles of triplet therapy, or at least 9 cycles of quadruplet therapy, you must be giving to have this MRD negative status. The whole idea of multiple myeloma, it's a non-curable disease. But once the disease is under control, you will like to have as much as the progression-free survival, the patient to achieve that PFS. OS may not differ too much, but of late, with the entry of bispecific, the OS is also making a changes. So what this initial therapy, at least the patient should have a good PFS is what the need of all myeloma treatment. So the goals is to get quick disease cytoreduction an MRD negatively high response MRD reversal of end organ damage, improvement of performance status, minimal toxicity, allow adequate stem cell harvest. Okay, so this we were discussing. This came up triplet versus quadruplet. So we being in the Delhi, we may not have that. Especially still Delhi is not very uniform. At the corporates, when you are sitting, you know the patient when it comes, we have to say that okay, we are giving quadruplets, triplets when they demand for it, or if there is a financial, most of our patient will go for quadruplet. But this may not be the scenario. So just any of you can take how many percentage of patient go for quadruplet, and how many patients go for triplet therapy?
So, sir, my around 70% of the patients are on triplet therapy and 30% around quadruplet therapy. The reason behind that, one is the cost issue. So, even after counseling of 10 patient, only 30%.
So provided the economics is taken care of, most of our patient will go for quadruplet therapy.
Yes.
We are waiting for the generic Darzalex to come, and I think so the majority. I don't think so. After that, things will
Yes.
be the same. It's going to be more toward quadruplet therapy, and we are well versed. Quadruplet therapy, better. It's cutaneous version. It's not the efficacy, and we do not believe in that data. Only thing the economics which makes us little bit. Not all patients are going for the quadruplet therapy. Okay, so triplet therapy also we are using VRD or VCD based treatment depending on the renal profile. Anybody in the triplet therapy, upfront use of carfilzomib as ASH25, we have paper. Do we use carfilzomib upfront? Means we have done the fish, we have, or we are still the tag time of fish is sometimes 10 days to 2 weeks. By the time patient is already on bortezomib based therapy. So do we, any group of patients, sets or any prognostic apart from fish when we decide, okay, carfilzomib has to be given upfront? Do we have that? Any?
Sir, only one patient I have given because the patient had pre-existing neuropathy. So bortezomib is relatively contraindicated. So in that patient only I have used carfilzomib. Otherwise, my all patients are on bortezomib-based therapy, of course, only.
Rohan, you
Similar, most of the patients, if we go for quadruplet, we actually prefer to go for daratumumab. Not only because the patient is high risk, also you have to look into the comorbidities and the toxicity of the drugs. So because of that, we do not use carfilzomib upfront most of the patients.
Most of the patient. Rohan, anything you want? Same thing. Sure, thanks. So this is the scheme of things. When you use quadruplet therapy, transplant, LEN plus or dual maintenance or single maintenance, depending on the risk stratification, or if it is transplant ineligible, at least 9 to 12 cycles you should be giving. This is the NCCN guidelines. We are aware of it. This is some data of the Cassiopeia trial and the Griff. If you can see the Forte trial where the carfilzomib was used when the KRD transplant or KRD transplant or KCD when it was not much difference, but the whole thing is carfilzomib upfront was much better outcome in the high risk cases, not the standard risk, but the high risk, it made the difference.
Dr. Reyes. Yeah.
Yeah.
Sorry. So, in term carfilzomib, the guidelines mention in 2026 that if you have an ultra high risk, it is better to use carfilzomib compared to bortezomib. That is, I think, wanted to know the panelist opinion, because that is place where you should replace. Carfilzomib is not that expensive. It is not that difficult also to give. And second thing is, in transplant ineligible patients, um, if you have triplet versus quadruplet, I think Cepheus trial showed something contradictory there. The standard risk did better in transplant ineligible compared to transplant eligible. Thoughts of the panelist.
Data is there that carfilzomib is better than bortezomib, but when we have the opportunity of a daratumumab, then I don't think carfilzomib comes up fast in the answers. Yeah, so obviously in a high risk patients, carfilzomib adds better, but generally we prefer daratumumab in those situations because to overcome those complaints. Because first of all, daratumumab now we have a subcutaneous daratumumab which is gives a ease of applications, and secondly the toxicity profile is much less, and thirdly, the side effect profile, specifically the infusion toxicity, is not there with subcutaneous therapy. So that's why it's a very well accepted options.
So I'll agree. Ultra high risk patient, Dara KRD, favorable, no doubt. But that we have that most of the time we are too, yeah, yeah. So it's we are too busy, or we say it's the spinal level which we act. Before those data comes in, the patient is already on one. We have our own way of working. Okay, Dara VRD, Dara. So mostly what we changes is the creatinine. If you have got creat high, you go Dara VCD way, or if it is normal Dara VRD. Later, when you see the fish report, by the time patient has already taken our 1-2 sessions of the therapy. So that's, and again, so in transplant ineligible cases, standard risk when you give the more. Now, see, we work in totally different scenario. Although the standard risk, most of our patient will have more infective episodes, especially when you are using anti-CD38. It's easy said being said done. The IgG level goes down. So one more drug is being added. The longer duration of when you use Darzalex, later in the time you will be giving more and more of immunoglobulins. So it's not that only Darzalex which is costly. The later that IVIGN is in infective episodes in India is more higher. What I feel, although we have been using more than 90% of our patients goes on quadruplet, but if we do not use immunoglobulins at a regular interval, we are going to face more and more of infections. So, Perseus trial, what we follow commonly because of the subcutaneous, it's much better than the intravenous. I think so. The use of intravenous Darzalex has come down. So, any problems when the Darzalex came down, the IV Daratumab was there? Any specific problem when we used to see my colleagues from the lab?
Actually, when we are using IV daratumab, most common adverse effect you used to see is the infusion reactions. That is the one problematic. And as prolonged treatment, we have to give about 5 to 6 hours. That, in comparison to subcutaneous, it's very easy to.
Very easy. Yes, Rohan.
Some blood group
Yes.
mismatching kind of issues used to occur, sir. Probably that has come down.
Yeah, blood group issues was there, and also when you used to do the analysis of serum protein electrophoresis, there used to be small band of Darzalex. It never used to be zero. It has to be point one point and the query. But you can easily differentiate between that M band versus the Darzalex band. So once you compare those initial serum protein electrophoresis when you're doing at the end, so that also needs to be taken, that it's okay, it's not the Darzalex band, it is the it's not the disease band, it's the Darzalex band. Okay, so transplant again, not more than 20%, what I believe. Yeah, just 2 minutes. 20% of the patient goes for transplant. I think so. This is what we see in the. What's our take here? How much people go for transplant?
So if we see that for the patient who are transplant eligible, I will say around 40 to 50% patient goes for transplant in our setup. But obviously, sometime it is delayed, not at the ideal time point. Sometimes it's delayed after achieving the response. They may take around 3-4 months. After that, they go for transplant. In some point.
Sure. So it's being discussed in, I think so, but I feel a transplant is now the cheapest therapy available. With the bispecifics on board, the transplant does make a difference in the patient's life. And although quite toxic for few patients, but nowadays transplant hardly 6 lakhs to 8 lakhs, one shot therapy, and it can bring the disease under control for at least 2 to 3 years. That's what we can say. So one of the cheapest therapy at present available is the autologous bone marrow transplant for the multiple myeloma. So I'll just go for the maintenance. One last question. How important is the maintenance in multiple myeloma? Anyone, please.
So maintenance has shown to provide benefit in terms of progression-free survival. So we routinely offer maintenance to all the patients.
So Mahesh, single agent, double agent.
So, sir, high-risk patient, double agent, lenalidomide plus bortezomib, and in the standard risk patient, single agent lenalidomide. This is our
Anybody else have any other views? Dr. Rohan, anything else we can use?
Commonly these two, sir.
These two patients. Okay, sure. So Darzalex is also, if those we can use Dara plus Len or Dara plus Bot. How long we can use the maintenance therapy? Or how long should be using the maintenance therapy?
sir, for indefinite period. In our practice, we are not doing MRD. So if we are doing MRD, at least 3 years negative MRD, we can stop maintenance. But in my practice, I am giving indefinite.
Sure.
Yeah.
So these two maintenance did make a difference in the myeloma 11 trial. It did shows that PFS was better those who have prolonged. But nowadays the trend is that to stop the maintenance therapy, but that is based on the MRD. You have to do MRD at least every 6 months, basically every time. So you should must have sustained MRD negativity. The word is sustained MRD negativity to stop the maintenance. So that is new, but until unless we start doing MRD at different time point, so that time in India at least we have to continue. With this, I will just stop the panel discussion. Thank you.
So I have one question. Sorry. So this is regarding myeloma transplants. Uh, just wanted to ask, are we really transplanting according to age or ECOG plays a role in that? Because I have a patient, 71-year-old, very fit guy. He was refracted to VRD, KPD as well. With LAN, he got some skin reactions. Started him on KPD. Uh, with KPD also, disease was persistent. So I counseled him for daratumab. He got 6 doses of Dara. He cannot afford any more Dara, but the disease is under remission. He's 71. ECOG is good. Should I transplant him?
Why not?
I mean, we can. There's no age limit to it.
It's not. If performance status is good, reduced doses of melphalan. It's not only the 200 milligram. Even 140 in more than 65 is good enough. 140 milligram per meter square. Yes.
Sure, I agree with sir. So age is just a number. Uh, since Miss Sir is also here, so geriatric assessment, if you are able to do, prove your fitness, you can definitely go ahead with that.
I just had a doubt when you were discussing about maintenance for high risk versus low risk. So what I routinely do in my practice is, if it is high risk, I go for bortezomib maintenance, not the dual. One of the panelists was saying Vorti plus LEN. So what I do in my practice is, if it is high risk, I do only Vorti, and if it is low risk, I continue with LEN. So is there any benefit of adding LEN to Vorti for high risk in maintenance?
Yes, dual maintenance does make a difference in the high risk mutation. So, high risk single agent is not effective. If it is, you can add Darzalex plus Len, that is better than bot Len. Again, economics plays much. Dara plus Len, yes.
But then once your 16 weeks of VRD is over or non-VRD is over, if there is good response, and then high risk versus low risk. So high risk, what I practice is they will do
Okay. So again, if you are using triplet, please use 12 cycles of VRD. If you are using quadruplet, 6 to 9 cycles of quadruplet followed by maintenance. Maintenance again, low risk LAN is enough, but high risk again, depending on the what is your financial, para LAN will be better for the high risk. And if not, then bot LAN is good enough.
So one last thing. The ejection fraction of that patient is 55. 50, it is going around 50, 55. Will that be okay to take transplant, sir? With melphalan 140?
55 is good enough. What's wrong in 55?
Because in carfilzomib also I have given him reduced dose because of that ejection fraction only. Just wanted to
55 you said, no? 50.
See, it was 50 initially, so I assessed that again after 6 cycles of carfilzomib. So again,
It is 50, more than 50.
50.
So you can go for 40 milligram per meter square.
Thank you, sir.
So thank you.
Thank you, sir. I request our panelists and chairpersons, please felicitate our moderator with the memento. Please join the stage, our chairpersons, please. Thank you, sir. I request our chairpersons and panelists, please collect their mementos from the memento desk. And for this, I request Dr. Neha Jain, please give mementos to our panelists and chairpersons. In continuation of our hematological malignancies, we have another panel discussion on diffuse large beta cell lymphoma navigating cases scenario. For this session, we have Professor Dr. Atul Sharma. He is Chairman, Medical Oncology, Max Saket, Delhi. To chair the session, I would like to invite Dr. Priya Pathak, Dr. Kalyan Sen Gupta, sir, Dr. Animesh Chaudhary, Dr. Ankit Sharma, Dr. Rajkumar Paranwal, Dr. Nimesh Sahu, Dr. Manjula Beg, and our panelist, Dr. Saroj Bala from Raipur, Dr. Amber Garg from Raipur, Dr. Adamya Gupta from Raipur, Dr. Nihar Gupta from Raipur, Dr. Ayush Dubey, medical oncologist from Raipur, Dr. Vilas Meshram, nuclear medicine from Raipur. Over to you, sir.
All right. Good afternoon. Good afternoon. And yes, so that's what I am going to do. So thank you, Ravi, for this invitation. So maybe that since I may not be knowing many of you, and like Ravi pointed out that maybe that I understand there is one nuclear medicine physician. So Vilas, Dr. Vilas, you are Dr. Vilas. Okay, so we are sitting from other side. So I don't want to take a roll call, but Dr. Saroj Bala, I can understand. Then, um, oh, she's not here. Oh, okay. So who all are not here is, but I think so. Amber is here. Amber is here. Then Adamya Gupta is here. Then we have the Nihar Gupta and also Ayush Dubey. And we have the Vilas. All right. Thank you very much.
So we start, and based on the timing, we can stop at any point in time. So basically, these are the obviously, since we are discussing the DLBCL, so I thought that maybe why do you want to discuss DLBCL in 2026? Obviously, with regard to the treatment outcome, we have been seeing that more than 30, 20, 25 years, probably 1918, 98 or 99, R-CHOP was introduced. So now we have the more evidence that there may be something better than what we have been practicing for DLBCL. Also, we are getting more and more evidence that this is not a one disease at all. There are some biological driven treatment is available, and we are understanding tumor biology and the lymphomagenesis also. Of course, in our setting, it is very important that we discuss cost versus value in the real world setting. Clinical trials apart, corporate sector, government sectors, affordability, they becomes very, very important. So our discussion will be based on these guidelines, basically. So straight away I'll start, and probably I'm moving, except for the nuclear medicine physician, from left to right. So this is the first case, probably 58-year-old gentleman detected to a stage 4 lymphoma, IPA was 3, biopsy was non-GCB variety, performance status was 3, mainly because of the disease. He did have B symptoms, no comorbidity pre-existing, and of course we did all the investigation. I don't want to waste time. What else we need to do? Bulky disease, high LDH. The one point I would like to ask the panelists is do we need to do bone marrow biopsy in 2026?
Uh, Sir, in our practice, we are doing in all the patients bone marrow.
Everybody
Excluding PET
agrees to
scan
that, or
right
is there
now.
difference, or we can do away with bone marrow biopsy? Can match anybody?
So actually, if the PET is done and if it is showing that there is no marrow uptake and there is no diffuse involvement of the marrow, might skip. But since all the lymphomas are quite patchy, uh, it's not even wrong to do it. It's not even
It's a painful process. If we don't need it, why do it?
so
Liver. That's why I requested you to come over this. All right. So the same question goes to Dr. Vilas. But are you confident you'll be able to pick up the bone marrow disease based on the PET CT or the thing?
Yes, sir. We can find out.
Are we justified? Because now Hodgkin's long back many years now we don't do bone marrow unless we have certain situation. Non-Hodgkin's also we can do away with the bone marrow biopsy.
No, sir. FDG can find out the bone marrow involvement.
And the last what Amish. Okay. So I think most of the time, unless
let me just come up with this thing. Like if the marrow says that there is, if the PET says if there is diffuse marrow involvement, query reactive, then in that case, I would prefer doing a marrow, and
agreed,
otherwise we might skip it.
agreed, agreed. So the question goes to nuclear medicine.
If the PET scan says that there is no marrow uptake at all, and you already have stage 4 with liver involvement, there I think we are justified in skipping bone marrow. If
Absolutely.
the PET says there is a patchy involvement of the bone uptake, there it is better to do the bone marrow.
And if there are cytopenias or this,
There are cytopenias, unexplained cytopenias.
all right, very educated. Now coming to the, so number one, the last question was that how best to treat this gentleman? He is young patient. You can start from that side.
The question.
So what best treatment protocol you will choose for this
So
gentleman?
yes, so high grade disease, sir, he is ABC. So I'll go with polatuzumab for sure in this patient.
Okay. You are okay with the polar HP.
So stage 3 disease ABC subtype, Pola has better PFS.
Okay, stage 3 ABC subtype. Stage 3, stage 4. Basically, we are talking
Stage
about
4.
the
Yes, yes, stage 4. So
But
3 and 4. High, stage 3
IPA.
and 4. We should take polatuzumab under consideration for sure.
What is the advantage we are expecting over R-CHOP?
So there's only in high grade disease, say stage 3, stage 4.
What
Only
advantage we are expecting?
the only benefit we have is PFS benefit. Around 5 to 6% of PFS benefit we have with polatuzumab. Obviously, the costing is way too much. It adds on to some 12, 13 lakhs rupees of cost. The costing of polatuzumab itself is 12, 13 lakhs rupees. So that will add on to the cost.
I don't use very often, but I believe it must be more than that.
That's
Everyone agrees, all
Yes, sir.
clinicians agree, polar CHP.
Polar CHP, I also agree.
Okay. Okay, so that is based on the PFS benefit. So all of us also agree that PFS benefit is adequate, good enough to change our practice, or we want to this thing change based on this thing. This is not something like breast cancer where we really need a long follow-up to get at this thing. This is this gentleman stage 4. Likelihood of developing relapse or progression is probably next 2 years or so. We can very well wait for the OS data to mature and then change our practice.
No, sir, because ultimately, whether patient receives polar CHP or R-CHOP, if he relapses, he has to be given salvage chemotherapy, which is same for both of the groups. So, anyhow, if we are getting that additional 6.5% PFS, it benefits in the long
So
run.
the moot point is that whether we change our practice based on the PFS data or we wait for the OS data to mature, which probably now we do
So
have some.
actually, similarly in Hodgkin, we changed our practice based on PFS itself. So why not
Okay.
in DLBCL?
Okay, that is one point. Anything else beyond that?
Sir, there is decreased risk of death and progression in this trial. So that thing, I think we will choose that because of that.
So these are few of the reasons, and I probably, if time permits, I can show you the examples also where probably we have been changing basically the reason for choosing PS changing practice OS often delayed in lymphoma. We may still have the delayed salvage therapy dilutes overall survival because whatever like you said, whatever we whether chop R chop or polar CHP, the next line of treatment salvage will be probably prolonging the survival, and this reflect the disease control, and this has been used in the past for the approval and practice changes. There are many examples. Polarix is one. Then we have the Echelon trial for the Hodgkin's disease, where probably based on the PFS only we change this thing. Nevo AVD versus BV AVD, also the PFS for the primary endpoint. Post BV, post ASCT, also based on the primary PS. So there is ample evidence that maybe that based on PFS we may change in the lymphoma. The important question I would like to get this thing is, so which are the patients who may not be suitable for the polar RCHP? I have listed here, but beyond that, or you want to evolve or dwell on one of these sectors, there are a few
So
sectors.
patients who are GCB type and younger patients,
Okay.
I might choose R-CHOP.
Okay.
And of course, low risk patients and patients which were excluded from the trial, like indolent lymphomas transforming to this.
Okay, we are talking about DLBCL.
Yeah. So basically, low risk patients and patients who are younger of age and GCB phenotype, that I might choose R-CHOP.
Any reason for
An economical
excluding younger patient? Did you say younger patient?
Yes, sir. The data was much mature in more than 60 years, which I heard saw in this article. More than 60 years, stage 3 to 4, IPI 3 to 4, they had more benefit in PFS as compared to other patients.
So am I getting for the younger than 60, we are not using it?
No, no, we can use, but like if the patient is a low risk patient,
Because in India, for median age, what we see in the Western population is altogether different than what we see in this thing.
right?
If that is this thing, probably most of a patient we won't be able to use RC, polar RCHP.
So I would lean in patients who are having a ABC, this non-GCB type, and
diabetic patient with
right.
pre-existing neuropathy. Anybody else want to? I think I don't.
Sir, actually, patients who have double hit lymphoma, like c-MYC rearrangement positive along with BCL2 rearrangement positive, I would prefer POLA. Some patients with limited stage disease and GCB phenotype, I would restrict myself to RCHOP. So less IPI score, I will restrict myself to RCHOP. Somebody with comorbid peripheral neuropathy existing, maybe due to diabetes or some other cause of neuropathy, I will restrict myself to skip to cola.
So double hit and triple hit. So was there a stratification? No.
Actually, sir, in the trial, Polarix, the data for double hit and triple hit, the number of patients were around less than 8%. So, not according to the Polarix, but
I'm asking because you said that double hit and triple hit you prefer to use.
yes, sir,
RC.
because double hit lymphoma and triple hit lymphomas, they are much more aggressive and high grade.
Aggressive always doesn't mean that the aggressive treatment will be more useful.
Sorry, sir.
Aggressive always doesn't mean the aggressive treatment may be useful. That is the case, we would have the enough data to say that the first remission autologous stem cell transplant will be useful in aggressive lymphoma or double hit lymphoma or triple hit lymphoma.
So
What
for-
I'm trying to say that I am not aware of the data which says that with the double hit or triple hit lymphoma, if you use our pola RCHP, you are doing more justice to the patient. You are expecting better outcome.
Yes, sir.
If the data is there, I would
Yes,
like.
sir. Data in itself, the Polarix trial, number of DHL patients
They
are
are small.
although the population was
This
small,
it is
the
difficult to
data was like good data. It was to be used.
So one more thing for double hit, are we going to prefer ARDA epoch or Pola? I would prefer ARDA epoch rather than
I do
Pola.
the same.
So for ARDA epoch, it also requires patient to be fit. Somebody, because I have one patient who is 60 years double hit. So stage 4 disease with the spleen involvement, pleural deposits. So in that patient, 60 plus, although he is a hockey coach, uh, he was not fit enough to receive high epoch at the first. So we started with Pola RCHP, and after 4 cycles itself, he became NCR.
So what I would say is that for the fit patient, because of the unfit patient, because of the disease has a different meaning, you can always use the pre-phase treatment and probably next within 2 or 3 weeks, because this is such a sensitive disease. And aggressive lymphoma, probably they will respond faster. That is anyway. So we come to the nuclear medicine, probably Dr. Vilash. So we are heavily dependent upon this thing, interim PET and all this thing and this thing. So number one, for the disease assessment, you suggest 2 cycles, 3 cycles. Is there any consensus among the nuclear medicine physician that we should be doing the interim PET after 2 cycles or 3 cycles? Most of the data for the Hodgkin's is PET2 and this thing. So for the PLBCL, non-Hodgkin's lymphoma,
Yes, sir, it is better to do interim PET-CT.
so we space it at 2 cycles, 3 cycles, 4 cycles.
4 cycles, sir.
Anything between the two.
Yes, sir.
Four. Okay, that is, I think, something. So the next question, you can read it for yourself. What is the expected margin of false positivity on interim PET due to post-treatment inflammation? And in India, of course, chronic inflammation or granulomatous disease.
It's a very rarely, sir.
So I don't think that that is rare, because in our own experience, I think some my colleague at AMC, when he used to be Samir, probably did this thing. It's not uncommon. And it is
around
always
50
suggested if you find it's residual disease and this thing, you must do a biopsy and prove or disprove it.
Sir, but we are doing a comparison with dual score. So 1 to 3 enough to decide the therapy, further therapy. And any experience nuclear physician can
All right.
describe.
Point taken. Amish is.
So,
Sorry,
uh,
go ahead.
just one question, sir. Are we doing interim PET in every DLBCL patient or only with bulky disease?
I would say yes in all.
Yeah. So about the sorry, yes, we do interim PET. About the Duvalier score, it is so subjective. In the chest, you will take the mediastinal pull. In the abdomen, you will take
Liver.
the liver uptake. Every time I have a fight with my pet guy, especially when you have a mixed response, you have 90% of the disease which has become Duvalier 1 and 2, and you have one lymph node in axilla or one lymph node in cervical, which is 3 and 4. And as Atul sir said, we nowadays do biopsy in all these. And we are surprised more than 50% of the time they are not lymphomas.
Last question, one small clarification for myself and my understanding. Does the dose of the FDG matter?
Yes, sir.
So because in Delhi, so one center will be charging 30,000, another center will be doing the same study in 20,000, then the 10,000, 8,000, 12,000. So probably what they do, I heard from the my colleague at Ames and this thing, so they probably the same dose they will split into two or three and this thing. Does that matter?
It's a
Smaller dose of the this thing FDG?
It's a dose must be
What
measured
is the minimum dose which should be given? This is a practical first problem for many
for
of
a
us.
60 kg patient. It must be 6 to 10.
To 10.
Yes, sir. Millicurie.
All right. So of course I can base, we have discussed the first line treatment and this. Of course, we come to the second course, time is short. So this is double expressor. And how do we proceed? Anyway, to make the life easy, probably we did the fish study, then probably that confirms this thing that this is double hit lymphoma. 42-year female, again bulky disease with the stage 3. Does it change? Probably the question we already had this thing. So is it dose adjusted epoch or is it the pola here? So all of you will consider pola here.
So I will consider Pola.
Okay.
Pola CHP.
That is that based on the subset small number of the.
Sir, on the basis of this double expressor lymphomas are usually of non-GCB type. So that is one thing which I thought that on that
Okay.
basis, I would consider Pola CHP.
So actually, it is double expressor and not double hit. So we can even proceed with RCHOP. Maybe if the fish reports come positive for both the rearrangements, then we might consider Pola here. And if the patient is fit, why not for DIPOC?
So, sir, what you are saying is double expressor versus double hit. Polarix, sir, later on, Polarix, because of small number of double and triple hit, they have excluded those subgroup from those subset analysis because they felt there enough power is not there. And Pola RCHP is right now not recommended
So
in
what
double
will
and
you
triple
do
hit.
in this case?
So DR epoch
All right.
is even though randomized control trial failed, but we have enough phase 2 data. And if you see the historical comparison with our job, I think DR epoch gives us good
All right.
results.
So take it. So last question, I think so. Obviously, this is a clinical problem we encounter. 76-year-old male, performance test 3, ejection fraction 40%. Somebody wants to let us make it 35%. Bulky disease obviously is not suitable for endocycline. Everybody agrees that. Even the mini chop. So what are the options here?
I'll go with RCOP, sir.
RCOP, you replace endocycline with etoposide. Anybody else?
I agree with him. Either I would go for RCOP or RCVP.
Amish, R mini chop 40%. Is 78. 40%. All right. So what will be the, if you are using etoposide based treatment, what will be the goal of the treatment? Just palliation I can achieve with the RCVP, or you want curative intent treatment?
Depends on the performance status and the.
I said you 76 ECOG 3.
So, sir, in this patient, I'll mostly go for palliative intent rather than for the curative.
Sir, this could be because of this ECOG3 could be because of the disease as well.
All right. But
So
cardiac functions are deranged, definitely.
yes, so we can give prephase and see if the
Most of these patients nowadays end up getting prephase.
so we can go with etoposide rather than doxo for sure.
All right. So your also is palliation. I still probably confident maybe that we should attempt this thing, curative intent. Obviously. So obviously these are the patients, and I believe time is up. Any comment or question from the audience before we close this? Yes, please come forward.
Sir, I have two doubts regarding one of the comments from your side. Sir, you had told that we do routinely do interim PET in most of your non-Hodgkin's lymphoma. But is it for a prognostic value or a predictive value? Would you change the therapy based on your interim PET?
Very expert panelist here.
So that's what I meant when we spoke about interim PET. If we have bulky disease and we have to add RT after chemo, then we should be, I guess we should be doing interim PET at that moment.
But would you be considering changing your therapy after 4 cycles of interim PET? If there is a residual
Yes,
disease?
if then not, we will add we'll complete 6 cycles and we'll add RT, I guess.
But what is the purpose of continuing another 2 cycles of therapy if the dual score is 4 or 5 after 4 cycles of R-CHOP or POLA RCH?
So if only that bulky mass is left out, if it is uh, not less than 8 centimeters, I would say, then we should continue with RT, that localized RT, IFRT. And if we have progression of disease,
End of therapy, the consensus is at the end of therapy, if there is a residual disease, isolated residual disease.
So I'm getting the question. What he's trying to ask is that essentially for Hodgkin's, there are clear guidelines that we change the treatment based on the interim report.
that depends upon the DS score, sir, I guess. That depends upon the DS score. If DS is between 1 to 3, and if you have
That's why we do this thing. So PET, interim PET, we do to understand what is the result.
Do after, because
You are right, but I can recall 3 to 4 patients, and it's a saddest day in medical oncology's OPD when interim PET is 4 and 5. You feel very sad, but I remember 3 to 4 patients I have changed the treatment, and so if you are giving CHOP, I have given half to those patients, explained to them, and they have done well. One retrospective patient later on turned out to be high grade mental cell lymphoma. So Arasi based treatment was given, and patient did well, even doing well till now also. But sir, yes, what would you do?
So basically, what I would do is that basically number one, this is off definitely for the response assessment, prognostic value. You may not change the treatment. If you are doing it end of the 2 cycle, you can do another after 4, 6 cycle and see. These are the soft indicators this patient is unlikely to be doing well in the long term and may be requiring salvage treatment in near future, followed by transplant or CAR T as the facility may be there. So based on the changing treatment, based on the interim PET, we don't have enough data for non-Hodgkin's lymphoma. For the Hodgkin's disease, the guidelines are very clear that you do it after you find 1, 2, 3, then you can just continue with this thing. 4, 5, you do a biopsy and escalate the treatment, what the treatment has been given.
Thank you, sir. And another question is regarding the double hit lymphoma.
Sorry?
Double hit
Double hit lymphoma.
Double hit lymphoma. In the 5-year survival data of Polarix trial, they have mentioned like a double hit lymphoma constitutes around like 54%. As per the investigator classification, high grade B cell lymphoma with a double hit, that is like around 10%. But double hit lymphoma per se, patients having double hit lymphoma in that study were like 34%. So it,
No, 34% is probably expressor and double hit are two different this thing.
sir, in the
So ISC need to be confirmed with the fish.
okay, because they have got the both class without
Any comment from the this thing panelist?
Double express those percentage are of DEL. Double expressors means
that I understand because in the subgroup classification which they have mentioned, they mentioned both of it like.
Oh, Dr. Rayaj is here. Yeah. He can answer.
So Polarix was not designed for double hit. Again, double expressor is on based on IC, double hit is on fish, just sir was saying. Double hit as till now we don't have a standard of care. So people have been using dose adjusted epoch in comparison to R-CHOP. No differences in outcome, but toxicity was more in epoch, dose adjusted epoch. as Atul was saying, sir was saying that the POLARIX is yet very premature to say that double hit is good for POLARIX
Yeah.
is good for double hit. So we don't know. And to change our therapy based on this POLARIX data is also very premature. It may not be. We are seeing the trend. Initial trends are yes, stage 3, 4 high IPI, ABC type is showing good 6 to 7% difference. Relapse rates is decreasing, but these are trends. In high grade lymphomas, when you need a curative treatment, PFS is not enough. You have to say that whatever therapy are you giving in the first line, it has to be curative. So too early data, maybe we'll have to wait for a few more things. So those are
Agreed, sir.
till now, but you can choose if the dose adjusted epoch, if the patient is fit, if it is unfit, you can go for polatuzumab based therapy.
Agreed, sir. Agreed. Thank you, sir.
During the lunch break. All right, thank you very much. So big applause to all of our panelists.
I request our panelist and chairperson, please felicitate our Professor Dr. Atul Sharma, sir, with a memento. Thank you. Thank you, sir. I request our chairperson and panelists, please collect their mementos from the memento desk. And I request Dr. Ravi Jaiswal, please give mementos to our chairperson and panelists. Dr. Ravi Jaiswal, please give mementos to our panelists and chairpersons. For the next session, we have Dr. Divyendu De, senior consultant hematologist and hemato-oncologist and bone marrow transplant at Palco Medical Center, Raipur. To chair the session, I would like to invite Dr. Sunny Sikarwar, Dr. Aras Sonwani, Dr. Buddheshwar Netam. Please join the dais as a chairperson.
So, thank you, Chairperson Sirs, and thank you, Dr. Ravi, for giving me this opportunity. This is a wonderful conference with a lot of discussions over burning topics in hematology and oncology. So, I'll be talking about this redefining success in the CML, the role of asciminib in the first line. So, we all know the treatment of CML because the CML is one of the disease where the treatment has already been changed and it's now a oral therapy which gives a more or less normal life expectancy to most of the patients. Why I say most of the patient? Because even though we are very confident about treating CML, there are few patients where we find it very difficult to treat these patients and to achieve the response or achieve the goals that we keep in mind first at the start of the therapy. So that is where we need to think of something else. What is the unmet needs in these patients in the first line of therapy? And that's where we should think over and over again to to formalize the treatment, initial treatment, so that they also achieve the treatment goals that what we want to achieve in these patients. So you know the largest trials that has shown that most of the patients, though they will achieve a complete response by 5 years, 95% of patients, but there are 5% patients who are not achieving the major molecular response, and the number increases as we go on, and it becomes 88%. That means 12% patients are out of the box by the 10 years. As we are now having these treatments, which is giving it a normal life expectancy, that means a large number of patients are there who are on treatments with the initial tyrosine kinase inhibitors and giving them a life expectancy, but they are failing as they are going on in their treatment. So this 10-year data, 88%, that will again come down after another 5 years and so on. And you will get a lot of patients after sometimes who are not achieving the optimal response. So that's where, and when we are talking about TFR, that is the treatment-free remission and complete cure, this number actually matters. So that's why we need to think of what we can achieve in these patients. And also, when we are talking about our normal life expectancy, the second important question is quality of life, because you cannot live your life in a miserable way for a long durations. So you need a good quality of life. And if there is complications, if there is toxicity with the therapy, then these patients will be non-adherent to the treatment, and that non-adherent means again failing to achieve those response. So you can see the major molecular response, the MR4, deep molecular response, and complete molecular response. These are failing down in those patients who are not adherent to the treatments, and that is quite a significant one, and that we do not want in any of these patients to happen these things. So we need some treatment which will be again oral therapy, a continuous therapy, but giving a good quality of life without having much complications, and probably achieving those deep molecular response and those response like treatment free remissions in this group of patients who are high risk. So you all know that the tyrosine kinase inhibitor is the standard of therapy right now for all the patients of CML, but they has got these off-target therapies, and these off-target toxicities are the important cause of their complications and toxicities. So we need, can we have something else? So that is one of the molecule, that is the asciminib, which is the stamp inhibitor. And this ask for fast trials already been published right now, and we all know the data that has shown. Here we have trial design was very unique, that first the patients came to the with the diagnosis of CML, they have been counseled whether they want to go for a imatinib or a second generation TKI, because we all know that we have our criteria to define whether we can go for imatinib or a second generation TKI. Then after they have been decided what will they will go for TKI, then they have been randomized whether they will receive that optimal choice of TKI or asciminib in this group of patients, and then they have been continued on follow up and looked into for the efficacy data. And if you see the different initial data, the most of the patients who are who are elder, who are having comorbidities, who are having high Framingham score, they are receiving imatinib rather than second generation TKI. And those who are having a high ELT score, they are receiving more for the second generation TKI than the imatinib. That is what we do commonly in our clinical practice also. So this data actually simulates what we are doing in our clinical practice, and they have compared it in a randomized manner to receive either asciminib or this choice of therapy. And they have shown obviously the asciminib has got a very high number of patients the achieving the major molecular response at week 48. Optimal treatment target, that is the achieving a major molecular response, which actually correlates well with the overall survival. So major molecular response achievement is around 20% more in patients with asciminib than either the first generation or a second generation TKI. And if you can see, even for the second generation TKI, there is 10% increments with the asciminib than the second generation TKI. It has been shown that not only the major molecular response, the early molecular response at 3 months, and the deep molecular response at MR4 or MR4.5, all of them are showing a better response with asciminib than with the standard TKI. And this has got next comes the safety, and the safety trial shows that the adverse events are there, but adverse events are having more than grade 3 adverse events are much less with asciminib than with the standard TKIs. And if you see the different hematological adverse events, probably the thrombocytopenia, the first one, that is one where the asciminib has got a significant number, but which is comparable to the second generation TKI. And the rest of the things, neutropenia, anemia, lymphopenia are much less. And regarding the non-hematological toxicity, all of these toxicities are much less than the standard TKI. And probably the increased lipase amylase and increased liver enzymes are one of the important concerns, but not much than the second generation TKI. This trial has got a prolonged 96 weeks data also right now published. Again, they are showing that if you can see the gap between this response from the TKI and the asciminib, that has been persisted for the 96 weeks. So that means the response, the efficacy achievement is persistent for the longer durations, and similar for the MR4, MR4.5. That means the deep molecular response that is also having a 10 to 20% increments with the asciminib therapy than the standard TKI. Safety data, again, no increase in the safety profile. So, in summary, asciminib continue to demonstrate this superior efficacy in all of these CML patients vis-a-vis the second generation TKI or the imatinib. And with the imatinib, the response rate is much better than the second generation TKI. The deep molecular response is maintained even at week 96 compared to the TKIs, and the safety and tolerability profile is quite matched, and it's better than the imatinib or the second generation TKI. So it's obviously favorable to use asciminib in all of these patients so that we can mitigate the gap that which of the patients who will be coming out or who will be out of the track in the long run with the TKI therapy. So this new trial can start. This is again another trial, which is actually an event-driven trial comparing the tolerability of asciminib versus nilotinib in a newly diagnosed patient. So again, in newly diagnosed patient, this trial actually looking focused on the events. That means the adverse events or the efficacy or the safety concerns in these patients, which is compared directly with nilotinib. And this is a long trial. So these patients will go on receiving TKI or asciminib for 3 to 5 years. And if they achieve the targets for the treatment-free remissions, they will go into treatment-free remissions. And if they face this treatment-free remissions, they will again have a treatment reinitiation. So it's that completely simulates the normal journey of a patient of CML with TKI, and they have been compared with asciminib. And this trial will continue for 5 to 7 years. There are initial interim analysis available at September 2024. The ASCO trial, there have been the report has been published, and this has shown that the significant superior tolerability with asciminib versus nilotinib. You can see in this graph the different events that has occurred in different time points, and you can clearly see the uh, increased number of events in the nilotinib arm than compared to the asciminib arm. The hazard ratio is 0.45. So again, the adverse event, mostly whatever happened with the asciminib is mostly the thrombocytopenia. Other than that, the other adverse events are much less than 10% actually. And you can see the favorable outcome, favorable safety profile in patients of asciminib compared to nilotinib. Similar happens in all the other non-hematological toxicity also. And generally these are all less frequent, and most of them are of less than one or two grade 2, less than grade 3. So higher proportion of patients also achieved a early and deep molecular response. If you see the first one, that is showing the early molecular response less than 10% at 3 months, which is in 90% of patients with asciminib rather than compared to nilotinib. And the deep molecular response, if you can see the MR4, MR4.5 is also achieved in major large number of patients with asciminib than with nilotinib. And we have to wait for the other the long-term data also to find out the other analysis. So this primary analysis again from on May 2025 last year, it was presented in ICMLF. What they have shown, this superior tolerability is continued not only at 48 weeks but also at 120 weeks also, and it is actually increasing. The gap is increasing. That means the tolerability profile is actually better, it's maintained with asciminib rather than nilotinib. So obviously the tolerability safety profile is much better than the other TKIs, and the efficacy is also maintained. So here it shows the early molecular response as well as the deep molecular response is much better than the nilotinib. So why not choose that drug which gives a long-term better safety, a better efficacy profile along with a very less toxicity profile. So the guidelines has also recommended this, that the asciminib can be used as one of the therapy in the first line in CML patient irrespective of their risk strategy. And these trials has also shown the similar results. So I will conclude here. Thank you. And also I will welcome all of you to our EIBM City and the HimaQuest conference that will be happening in 31st July, 1st August, 2nd August for a day long hematology discussions. Thank you. Thank you.
Thank you. I request our chairperson, please felicitate our speaker, Dr. Dibendu Dey. And now we have very important session, role of immunotherapy and its sequencing strategy in the management of head and neck squamous cell carcinoma. For this, we have Dr. Shantanu Pense from Nagpur. I request our chairperson, please be seated for the next session also.
So this is the last, and after 10 minutes, we'll have lunch. So yeah, let's honor our last speaker. Dr.
Yeah, I'll
Shantanu,
try to
over
wrap
to
in
you.
10 minutes or less than 10 if possible.
Thank you.
I'll run through the slides. Please don't mind. So today's this topic is immune role of immunotherapy in recurrent metastatic head and neck cancers. Yes, and its sequencing strategies in the management of head and neck cancers. So as we all know, oral cavity or rather head and neck cancers still form the chunk of our practice. Oral cavity most commonly, these are the projected numbers. Most of them have locally advanced or loco-regionally advanced disease. Distant metastasis not very rare. We are getting increasingly more patients of head and neck cancers who have distant metastatics pretty early. Male more than females. Most of the patients will receive multimodality therapy. Very few, nearly 10 to 20% will be cured by surgery alone. Nearly 40% will receive adjuvant radiotherapy, 40 to 50%, and 30 to 40% will receive systemic therapy, that is chemotherapy along with radiation, and chemotherapy or some form of systemic therapy in advanced setting. So previously, platinum-based therapies in combination with 5FU was the gold standard. Irrespective of addition of cetuximab, overall survival was dismal, nearly 8 months with or without cetuximab. Hence the need for uh, strengthening of the systemic therapies. So current guidelines suggest pembrolizumab as the standard of care addition to platinum-based therapy in locally advanced or metastatic head and neck cancers. So Keynote 048 was a phase 3 study of first-line pembrolizumab for recurrent metastatic head and neck squamous cell carcinoma. It had 3 arms: Keytruda monotherapy, which is practically irrelevant in our setting for the kind of head and neck cancers that we see. Pembrolizumab plus chemotherapy trial included carboplatin or cisplatin in combination with 5FU, and the comparator arm was extreme protocol, that is cetuximab in combination with platinum plus 5FU for 6 cycles. Primary endpoint was OS and PFS with stratification as CPS score, that is PDL1 CPS score more than or equal to 1 or more than or equal to 20. And secondary endpoints was PFS at 6 to 12 months, response rates, and EOR, the quality of life, safety and tolerability additionally. Nearly equal patients in all 3 arms. Similar characteristics in comparator arms, pembro extreme and pembro chemo extreme. When we look at these curves, significant difference in PFS as well as OS is seen more in favor of pembrolizumab in patients who have CPS more than 20. When we come to the patients who have received pembrolizumab in addition to chemotherapy, probably the CPS score is compensated for. So more than 1 or more than 20, more or less similar hazard ratios. So in short, we do see benefit in terms of PFS, that is progression-free survival, and overall survival with addition of immunotherapy, pembrolizumab to chemotherapy in patients who are PDL1 positive. Acceptable toxicities. Importantly, not significant difference in PFS, but tend to carry that benefit in OS, possibly due to crossover, also due to sustained benefit of immunotherapies that we have all seen in most of the other cancers with other immunotherapies as well. So long-term follow-up of the study confirmed statistically significant improvement in OS for pembrolizumab compared to cetuximab in PDL1 more than 1 or more than 20 both. Duration of response remained longer as compared to cetuximab, that is extreme arm. and safety was also favorable for Keytruda versus Extremam and comparable for Pembro plus chemotherapy. So, as appropriate sequencing as expected. Even this benefit persists for PFS2 as well. So I'll come to the conclusion. In view of improved PFS2 for patients who have received Keytruda in first line setting, in pembrolizumab addition to chemotherapy should be the standard of care for patients who are PDL1 positive, that is more than or equal to 1, more so in PDL1 more than or equal to 20. So Keytruda significantly improved OS irrespective of PDL1 score when it is positive. No PFS benefit for Keytruda. Keytruda monotherapy, PFS2 is longer. Keytruda had a favorable safety profile as well. And Keytruda plus chemotherapy had significantly improved OS in combination with chemotherapy as well. Thank you.
Thank you, Dr. Painse. I request our chairpersons, please felicitate our speaker with memento.
Thank you, sir.
Yeah.
Thank you. Thank you.
And I request our chairpersons, please collect their mementos from the memento desk. Dr. Sandeep Singhal, nephrologist from Ramakrishna Care Hospital. I request, please give mementos to our chairpersons, memento desk. And now I request Dr. Ravi Jaiswal for his concluding remarks and vote of thanks.
So, good afternoon. And 2 days were fantastic. I would like to thank each one of you who are sitting over here. But let me begin with, first of all, Ramakrishna Care Hospital. I think they have put up a fantastic show. They have worked day in and day out to make this conference successful, and still they are over there. So, right from our patron, Dr. Sandeep Dave and Dr. Vivek Chaudhary, sir, to our convener, Abbas Naqvi, sir, to our team, all consultants across departments. So, it was a full Ramakrishna Care Hospital, full house, and right now also the hall is full. So you can understand the gravity of this conference. And yesterday there was no place in the hall, so that was the scenario yesterday. So we had total 1,000 registration. I think a huge round of applause to everyone to make this so successful. And whenever we do a conference, so there is a team. So we have a team of Dr. Tarun Mathur from CRSF Foundation. I think these guys were working behind the scenes for the past 3 months. So they have done a fantastic job, all their team. Third is our sponsors, academic sponsors. So uh, 15 to 16 academic sponsor. I would not list all of yours name. And thank you so much. I think without your support, we couldn't have completed this journey for 2 days. So thank you so much. And you're still over there. So I really acknowledge your effort that has been put through. Fourth is our team over here, Dr. Manoj Soni sir, the man who was there from yesterday 9 until he's over there. All the announcement, he and his team, Dr. Chetna, uh, Dr. Ujwala, Dr. Neha. So they have done a fantastic job. Last is all of you, doctors who have traveled across India this conference to make this successful, to all our faculties across Chhattisgarh who have come. I can see Dr. Nagdev sir. He's from Madhya Pradesh, and still look at his passion. He's still over there, and this is the dedication which makes this conference successful. So thank you so much, all of you. And if I have missed anyone's name, my apologies to that. We are open for lunch, and I officially announce the closure of a successful conference, OncoSphere. And we will see you again next year, OncoSphere 3.0, bigger, better, bolder. See you next year. Bye. I would like to felicitate Tarun Mathurji. If you can come on the dais, please come. I would request Dr. Sandeep Dave sir, if he is here. Dr. Tamaskar sir is here. So, sir, can I request you to please felicitate? And can I request Mo ma'am also to join? Yeah, please. आ जाओ. Please come on. Please.
मैं लेके आ रहा हूँ.
Now we will felicitate Dr. Manoj Soni, who has done all the announcement for the faculties, right from the beginning of the conference till the closure.
Thank you.
हैंडल everything. तुमने हैंडल किया हम बैठ पाए सामने.
हमारे कॉन्फ्रेंस के हमारे ग्रुप कॉन्फ्रेंस के साथ
हाँ